Good evening, everyone, and welcome to yet another interesting and exciting series in the series of our Kerakonnect webinars. So the topic that we are going to be discussing today is on ocular surface tumors. And the scope of the webinar basically is to focus on OSSN, pigmented lesions, and lymphoproliferative lesions, and to stress upon the importance of communication between the clinician and the pathologist, the basic crux of the management of tumors anywhere in the body. On behalf of the Cornea Society of India, the CSI panel, and my co-moderator for the day, Dr. Rama Rajagopal, Director of Cornea Services at Shankar Nethralaya, I extend a very hearty welcome to our guest faculty, Dr. Santosh Hunawar, the Director of Oculoplasty and Oncology at CFS Hyderabad, Dr. Vikas Menon, Senior Consultant, Oculoplasty and Ocular Oncology at CFS Delhi, Dr. Bhaskar Srinivasan, Senior Consultant at Shankar Nethralaya, Chennai, Dr. S. Krishnakumar, Head of Pathology at Shankar Nethralaya, Chennai, and Dr. Kaustubh Mulai, Head of Pathology at CFS Hyderabad. Thanks to all of you for having joined us on this webinar today, and we look forward to a very interesting and interactive webinar with all of you. I would start with a very brief introduction on the topic. Firstly, focusing on why the stress on OSSN. Definitely OSSN amongst all the lesions is the one with the more common occurrence. Further increase due to the combination of a higher prevalence of HIV, sunlight exposure, and query HPV infection in our part of the world. And the spotlight has been on OSSN, especially since the advent of topical therapy, which therefore bypasses the AJCC staging of the tumor, and issues around the lack of very clear guidelines for choosing surgery versus topical therapy for this particular condition, which we look forward to will become more clear when we go through the course of the webinar. So let's start with a quiz. I'm going to have some questions that will be interspersed through the course of this webinar. And can we have the first question, please? In a lesion that is clinically suspicious of OSSN, what could be missed if you don't do a biopsy? You have 20 seconds to answer this question. Distinguishing between intraepithelial neoplasia and squamous cell carcinoma, a misdiagnosis, or identifying mucoepidermoid or spindle cell variants of squamous cell carcinoma. What could you miss if you don't do a biopsy? Okay, so 67% have answered the question, the response as 1. The first question in the series of quiz questions was actually a googly. The actual answer is all of the above. And this was just to set the tone of the webinar. Let's put our thinking caps on right at the start and get in tune and focus for the rest of the webinar. That's going to be very interesting. So I'm not going to go into the details of each of the options that I put across, but I am going to ask this question as to what are the possible implications of such a scenario if you do not biopsy a suspected OSSN, which means that you are considering starting the patient on topical therapy. So if you misdiagnose OSSN for a melanoma, what could happen? You could have a setback of 2 to 3 months awaiting a response. AJCC staging becomes defunct and cannot be used. And there could be a possible non-resolution or recurrence following resolution in the more aggressive variants. So this is something that we need to understand, then that when we go in for topical therapy, the clinician and the patient must accept possible misdiagnosis and hence over or under treatment of the condition. This is not to discourage or defame one treatment over the other, but this is just to emphasize and iterate, probably in Dr. Honavar's words, understand the science and triage the patient accordingly, which is something that we are going to go through over the rest of the course of the webinar. And this is exactly the reason why we are starting with surgery, followed by pathology and the topical therapy, and understanding the science behind each of these, and then focusing on the clinical evaluation of these lesions, which is where, sitting in the OPD, we are going to have to take the decision of triaging the patient into either the topical therapy group or the surgical group. And to do this, let us all be on the same page as far as what we understand with respect to the pathology is concerned. This is a representative figure of CIN versus SCC from the skin, with a similar pathology that we have in the conjunctiva, which shows the cell of origin to be the limbal stem cells, which are either dysplastic or you have them as malignant cells. But as long as these cells vertically respect the basement membrane of the epithelium, it falls in the category of being intraepithelial neoplasia. And the minute it breaches this on the right side of the arrow, it becomes a squamous cell carcinoma once it invades into the subepithelial tissue. And this basically helps us decode the AJCC staging for OSSN, which not only depends on the size and the extent of the lesion, but also the depth, which clearly indicates that histopathology is mandatory for the AJCC staging of OSSN. The tumor in C2, which is basically the intraepithelial neoplasia category in the AJCC classification, falls to the left of this red arrow, and the stages T1 to T3 fall on the right of this arrow. So when you look at this classification here, based on just a clinical examination of a tumor in C2 or the SCC, which belongs to the T1 or the T2 category, you cannot differentiate this clinically sitting on the slit lamp. So a lesion which measures, say, 8 millimeter in diameter, which you might place in T2 clinically, might actually turn out to be a TIS if it is only a CIN in the histopathology. Similarly, when you talk about lesions ranging from T1 to T3, with T1 and T2 on one side and T3 on the other side, what differentiates it basically is invasion of adjacent structures, which includes both the cornea as well as query the limbus, which is why you do have certain instances of misinterpretation. Because if you have a conjunctival CIN with an extension into the cornea, which is also a CIN, it may get wrongly placed in T3 instead of being placed in TIS, and you could at times have a systematic miscategorization of a carcinoma in C2 to a grade which is much higher than what it should be assigned to. So going back to the same figure, we understand again that the choice of treatment for the lesions which are on the left side of the arrow is basically topical, and when you're on the right side of the arrow, it is surgery. In the same lesion, in the same eye, you can have a combination of both squamous cell carcinoma as well as CIN, which is basically what forms the basis of giving both chemotherapy and surgery for certain lesions, as we shall see as we go forward. But this is something that we need to be on the same page to go ahead in the webinar. And you can also see that when you do an imprint cytology, all that you get is only information regarding the superficial cells, whether they are normal, dysplastic, or malignant, and it will in no way help you diagnose whether the lesion lies to the left or to the right of the red line. With this, we go to the first talk of the evening, and we always do a survey before every webinar of ours. And with respect to the first talk, which is on surgery, almost 60% responded to the survey saying that what they most commonly do is a wide excision with cryotherapy and alcohol keratoepitheliectomy, with more than 50% choosing a 4 millimeter margin, and almost 60% have responded that they never combine surgery with a frozen section. So the first talk for today is on surgical therapy for OSSN by Dr. Santosh Honawar, someone who never hesitates to call a spade. And those who have not read this editorial, it's a brilliantly written piece by him. And I think we must read this to get an insight into topical therapy versus surgical therapy. Over to you, Dr. Honawar.
Thank you, Geeta. Very nice introduction. And you brought out the problems with AJCC classification quite succinctly. I think that was really necessary. So oversimplification of AJCC has actually led to a lot of problems with our way of managing tumors. So I'm sharing my screen. Is it visible?
Yeah, go ahead.
Fine. So I'll go ahead with my talk, surgical management of ocular surface tumors. Geeta very nicely represented as to which cases are fit for topical therapy. It really works well in many situations as this. It's extremely useful and is very increasingly being used. There are specific indications for topical therapy, which is a matter of another lecture. But I would just begin with this. Surgery remains the standard of care, despite topical therapy being increasingly used. Standard of care still is surgery as far as OSSN is concerned. But the problem with surgery is that it has varied results. When you look at the literature, you find that up to 33% of these patients may have local tumor recurrence, which is at the highest end, the lowest being about 10 to 12%. It could be either because of microscopic residual tumor at the edge or base or systemic predisposition. So any of these three can lead to local tumor recurrence. And recurrence is the strongest factor predisposing to loss of vision, loss of eye, and metastasis. So if you have a bad outcome with surgery, that potentially can impact vision, eye salvage, and life. And that is the reason why first surgery is the best chance that we have to get rid of the tumor. So we began with this multivariate analysis for factors that are responsible for local tumor recurrence. We found that delayed diagnosis was a factor. Of course, we don't have much control over it. Diffuse tumor is also a factor for local tumor recurrence, possibly because of skip lesions. Diffuse tumors can have subclinical skip lesions, and those can come up later as tumors. Systemic predisposition is a factor for local tumor recurrence. Excision edge cryotherapy not being performed is also a very significant factor that predisposes to local tumor recurrence. And on histopathology, if the excision edge is involved and nothing has been done about it, that can also cause local tumor recurrence. And of course, as is logical, excision base positivity, if nothing else is performed, can also cause local tumor recurrence. So when we know all these factors can cause local tumor recurrence, we have to build these into our management scheme. So when we combine our excellent surgical skills with oncological principles, then possibly we can have a better outcome. Now, what are the oncological principles? Be it conjunctival surgery or eyelid surgery or even orbital surgery, there are very clear principles in oncology as to how to deal with malignant tumors. One is to have edge and base clearance. Second is neoadjuvant therapy. If you feel that during surgery you may not be able to get the entire tumor out, or having to do that might compromise on function of the eye, such as ocular motility or vision or integrity of the tectonic integrity of the eye, then you have neoadjuvant therapy to back you up. You can reduce the size of the tumor and then do surgery, which could be less radical and with more scope for salvage of eye and vision. Then we talk about histopathology guided adjuvant treatment. So following surgery, you have to have a very meticulous histopathology and use that information to guide further treatment. Then to prevent local tumor recurrence in those who are predisposed, you bring in local immunomodulation for those specific patients with systemic predisposition, and also use target therapy currently. So how do we improve success? By combination of all these approaches, right? From neoadjuvant therapy to surgery to adjuvant therapy and target therapy in a given patient, all this customized to achieve success. So how do we assess the extent? Of course, meticulous slit lamp evaluation. On top of that, if you use Rose Bengal, What gets stained are the subclinical areas. For example, this is clearly the tumor here. But what is also getting stained is all this area which may not be easily visible on slit lamp evaluation. So Rose Bengal stain will give you an extra advantage of detecting subclinical component quite easily, and beyond that 4 millimeter would be my edge. So I would stain all these patients with Rose Bengal. You can see again here that there are some parts of the tumor which may be very subtle on clinical evaluation, and that may get stained with Rose Bengal. So if you have a difficult situation, not in all cases, maybe you take a large diagram to the OT, because you would have had the best chance of evaluating the patient under slit lamp and with staining. When you draw this, everything will be clear, as you won't forget an area that needs to be excised. Under microscope, or when you're given a peribulbar block, there might be some subconjunctival bogginess, which may preclude you from a very good assessment on the table. So I would see the patient in detail preoperatively and have a surgical plan taken with me. And if you have a larger tumor, now let's come to neoadjuvant treatment. Larger tumor like this, where you think that excision would be too radical, then you can bring in neoadjuvant therapy. So what it does is, this is the tumor that we began with, and we ended up with this small residual. Why does that happen? The principle is very clear. If this is the epicenter of the tumor, that most likely is where invasive OSSN is, followed by carcinoma in situ, severe, moderate, and mild dysplasia before we encounter normal conjunctiva. Topical therapy takes away dysplasia and carcinoma in situ component, and what we are left with is invasive component of OSSN, and only that needs to be surgically excised. So this is a nice concept when we want to combine surgery with topical therapy. Now, what about the base? In this patient, margins are very clearly seen. But if you have to look at the base, then of course there is a clinical way of looking at it. Try to move the tumor on the episclera. If it appears fixed, then possibly you may consider episcleral or scleral invasion. You can do gonioscopy to see anterior segment invasion. All these are there, but they are not very objective. But what is really objective is imaging. Either OCT or UBM are very, very objective. You can see that in this patient, tumor is restricted only to the conjunctiva. This bubbly layer is nothing but non-involved area. Tumor is very compact, and your plane of dissection can be episclera. Here, how can we guess that this patient has full thickness stromal invasion unless we do imaging? To my surprise, this patient was found to have full thickness corneal stromal invasion, this being the normal stroma and this being the involved stroma. So there was no way of getting a clear base in this patient surgically. We have to either do a penetrating keratoplasty or do plaque brachytherapy for rest of the corneal residual. In these patients, there was never a clinical clue that these patients had anterior segment invasion to the angle and the ciliary body. Clinically, we couldn't detect it, and only UBM could help us. So in these patients, if you were to simply do surgery and leave the rest of the tumor in the ciliary body behind, obviously they'll have major recurrence. So imaging also correlates with histopathology. As you see here on OCT, you get the same on histopathology. That's a very good news. But the bad news is that in the presence of exuberant keratin, as most of these patients with OSSN have, then assessment of the base becomes very difficult because of shadowing effect. So OCT is good, but there are some limitations of OCT. When we talk about surgery, as most of you had responded to the survey very appropriately, excision with tumor-free margins is the key. Tumor-free margin is generally defined as 4 millimeter on the conjunctival side. So if you have a tumor lying here, you don't go 4 millimeter on the corneal side, because cornea being avascular, there is a very little chance of having skip lesions unless it's intraepithelial tumor. But on conjunctival side, you go 4 millimeter beyond the clinically detected edge of the tumor after having been stained with Rose Bengal. Then for the corneal epithelial component, we prefer alcohol-assisted keratoepitheliectomy. Cryotherapy to resection edge is mandatory. Cryotherapy to resection base is optional if on clinical assessment during surgery, if you find that 1 to 3 clock hours are involved little deeper, and you're not obviously going to get the histopathology for a week more. If you still want to go ahead and treat, you can treat up to about 3 clock hours of the resection base prophylactically. Lamellar keratectomy is reserved only for patients who have corneal stromal invasion, and lamellar sclerectomy for those who have scleral invasion. But for both these, now we have plaque brachytherapy. So you don't have to be aggressive with lamellar keratectomy and sclerectomy. Let's look at the surgery. This is a very straightforward case, simple tumor with a very localized tumor, where we begin with marking the edge of excision 4 millimeter beyond the clinically detected margin. Then excision can be performed with any instrument of your choice. But since I have an oculoplasty background, I tend to use RF electrode, which is a radio frequency electrode, which gives you very definite cut and you minimize intraoperative bleeding. So you see everything very clearly, and you can go very close to sclera with this instrument without any damage to sclera. Once you visualize the feeder vessels at the limbus, you cauterize them gently, dry the cornea, and then apply absolute alcohol to the leading edge of the tumor. And leave it on for about 15 to 20 seconds till it turns a subtle gray. Scroll off the corneal epithelium from the corneal side towards the limbus. So you reach the limbus from the corneal side. You scroll off additional 3 to 4 millimeter of the epithelium beyond the edge of the tumor without disturbing the Bowman's membrane. This is a very good barrier to the tumor. So disturbing the Bowman's would mean that you may have a stromal invasion. So you reach the limbus and then you resect the tumor right off the limbus under visualization. Some surgeons prefer a dry method, but dry would mean that, of course, there will be blood. So it is never dry. So it's good to wash off oozing blood with BSS so that you always have a clear field. Drape the edge of the conjunctiva on the tip of a 3 millimeter cryo probe and cryo from posterior to anterior so that you have a good endpoint to see. This is double freeze thaw cryotherapy with spontaneous thaw. It is during the phase of thaw that the cellular damage happens. So thawing should never be accelerated with skirting BSS. Then base cryotherapy, if you feel clinically during surgery that there was adhesion to the base at a particular clock hour, you cryo it already while you wait for the histopathology report. And if you're already cryoed it and if there is microscopic residual at the base, then you would have already treated it, so to say. So you don't have to go back to the OT again with the patient. Then repair is your choice. You can use a conjunctival autograft, you can use glue, you can use suture, you can use blood, whatever. But I prefer using glue and an amniotic membrane. And that's how the patient looks at the end of surgery and remains asymptomatic because of the use of amniotic membrane. Surgery remains an excellent option. There are very good results with surgery in terms of the recovery of the ocular surface and also vision. Even tumors which are about 6-7 clock hours around the limbus can be managed well with surgery. But if you have a much larger tumor where you fear that there is possibility of conjunctivalization of the cornea, limbal stem cell deficiency, etc., then you can resort to primary SLED, which has been a very elegant surgery described by Dr. Sangwan, to your advantage that these patients may not develop limbal stem cell deficiency if you were to use primary SLED. Then we finally lay the tumor in an anatomical position on a filter paper, scroll off the edges and send it to the pathologist for evaluation of the edge and the base. Now, coming to adjuvant therapy, it should be guided by histopathology, as I said. So when the tumor goes to the pathologist, if he reports that the resection edge is positive and it has only dysplasia and carcinoma in situ, since we already know that these two categories of the tumor can be treated with topical chemotherapy, that is one option. But if you have already subjected the edge to cryotherapy, then observation is logical. If resection edge is positive and it has invasive squamous cell carcinoma, then at least medico-legally you're bound to re-excise the edge, because we know that invasive squamous cell carcinoma cannot be treated effectively by topical therapy. If the resection base is positive, say one particular clock hour, and it is localized, if you've already done cryotherapy, maybe you can go ahead and observe. If you haven't, then you go back to that clock hour and slightly over-treat that area. If the resection base is positive, and unfortunately it is diffuse positivity, then the only option is plaque brachytherapy or go ahead and further excise the base, which may compromise on the tectonic integrity of the eye. If the patient is prone to recurrence, then of course we have to do immunomodulation. Now, we call this low dose interferon as immunomodulation. We are yet to have long-term results with this approach, but preliminary results are very encouraging. Patients of xeroderma and HIV who used to pop up a tumor every alternate month now lie quite for years together with this form of treatment, where we give once a day dose of 1 million international units of interferon indefinitely. Patients of this sort, xeroderma pigmentosum and HIV organ transplant immunosuppression patients do well with immunomodulation. The last bit is about target therapy. Now, I'm just not talking about OSS, and if we kind of extend this talk to even include lymphoma for that matter, if you have a patient with, say, predominantly conjunctival lymphoma with a part of the tumor going around the sclera posteriorly, you can't excise all of it. And what is left is treated with radiation, sometimes with complications. So short of radiation, you can use perilesional rituximab in these patients with excellent results. Rituximab is given in the dose of 5 milligram per ml, 3 to 6 injections spaced out 3 weekly, does very well for residual malt lymphoma in the orbit. Now about melanoma especially, we have molecular biomarkers. And if we identify molecular biomarkers, for each of these, there is a target therapy. You can see number of drugs that are already available, and some of these are approved. Reports are appearing in the literature about the positive effect of this target therapy when these were used in patients who had regional lymph node metastasis, for which these are approved. Incidentally, these patients can also have a local recurrence, and it seems to work. Like this patient with pembrolizumab, local tumor recurrence has resolved with systemic pembrolizumab. And nivolumab, of course, has also been reported to have good effects with conjunctival melanoma. And we had a patient recently where the patient had regional lymph node metastasis with subtle recurrence on the ocular surface. And for that, he got nivolumab. And after 3 months, when he came back for follow-up, his local tumor recurrence had completely disappeared just with systemic nivolumab. So it obviously has an effect on melanoma in the eye, either primary or recurrent. And this aspect needs to be further explored, although this particular uh, treatment modality is very expensive at this stage. And we also have checkpoint inhibitors, at least in the US, it's approved for orbital invasion, lymph node invasion, and also as an adjuvant therapy to prevent metastasis. Finally, when all else fails, if there is a tumor which is surgically inaccessible without compromising on the eye or with orbital extension, we can go for orbital exentration. There again, we do a lid sparing exentration so that the patient's socket is lined with smooth skin on which you can fit in a prosthesis. So in summary, I would say that although the reported rate of local tumor recurrence is ranges from 20 to 40%, we can achieve less than 5%, in fact, less than 2% local tumor recurrence with a suggested protocol where we combine oncological principles with surgical skills. Excision with tumor-free margins remains the treatment of choice for advanced OSSN, and oncological principles guide surgery. Thank you so much.
Thanks, Dr. Honawar, for that excellent overview on surgeries. I think there will be questions that will come in, and they were basically yeah, so we did have some questions that came in from our members before the webinar, and I think most of them have been answered, except for we have an overlap on a couple of things. Mm-hmm. One is about a coexisting fungal infection and OSSN. Before we go on to that, because I think the next question is also related to that. There is one question by Dr. Bharti Lavangya on what are the chances of limbal malignant changes in adult life after histopathologically confirmed dermoid excision in childhood.
Right. Dermoid is a it's a choristoma. So obviously it does not have malignant potential, but there is a variant of dermoid which looks like dermoid, which is called complex choristoma. Complex choristoma of the ocular surface is associated with the nevus sebaceous of Yadasin, which is a cancer predisposition syndrome. In those patients, there is a possibility of squamous cell carcinoma. They look like dermoid, the localized variant of nevus sebaceous, and the only clue is looking for systemic features such as what looks like choroidal osteoma, choroidal ossification or calcification, and bald patches on the scalp and greasy looking nevi on the face, chest, and abdomen. That is the only situation where what looks like dermoid or what looks like choristoma can have recurrence with vengeance with squamous cell carcinoma.
Thanks, Dr. Hunawar. Any comments on the coexisting fungal corneal ulcer and OSSN? This is, I think the questions were from Prabhakar and Dr. Radhika, where when you have a OSSN on the surface and when you have a corneal ulcer, then, how would you proceed in that situation?
Well, I think fungal ulcer takes precedence. OSSN is a chronic disease. There is no emergency in treating OSSN. But if you have to do an intraocular surgery, then possibly you have to deal with OSSN at the same time. Suppose you have to do a therapeutic graft in this patient and the area where you're going to trephine impinges on the area where there is OSSN, then you might want to excise it along with your therapeutic penetrating keratoplasty. But as far as medical management is concerned, I think infectious keratitis takes precedence over OSSN anytime.
Yes, I think what we are talking about here is those instances where you actually need an intraocular procedure. And if you are contemplating that, would it make sense to actually go ahead with the OSSN excision first in preparation of the need for an intraocular procedure even later, rather than doing it in the same sitting? Or do you think that we can just do the procedure in the same sitting where you excise the OSSN first, following all the principles that you have mentioned, and then, change your gloves, change your instruments, everything, and then go in for the intraocular procedure in the same stage?
Combining it would make sense unless you have a lot of time. Time in the sense that if you operate OSSN, you might have to wait for at least a couple of days before you do the therapeutic graft. If you have so much time, that's fine. Otherwise, combining it would make sense.
Right. I think this was a continuation of the same case where there was this leukoplakic patch on the lid, which appeared probably after the use of voriconazole. So the previous slide also, you can see a similar patch on the eyelid, and you have this. This was a question about voriconazole-induced dysplasia that is seen here in the lid margin.
Right. So as the person Radhika has pointed out, voriconazole is also a photosensitizer, and that can cause that is known. So, but this at the same time, this patient has a predisposition because the patient has xeroderma pigmentosum, and these patients can have tumors anytime, anywhere. So I don't think it is related to treatment or anything of that sort. And if you have leukoplakia of this nature on the eyelid margin, the best way is not to excise it completely, but cryo it.
I think before we move on to the next talk, we will just have another quiz question. The morphological type of OSSN that is most indicative of squamous cell carcinoma is gelatinous, nodular, or papilliform. So the response shows maximum people pointing out to gelatinous, but it would probably be the nodular variant of the OSSN, which is more indicative of squamous cell carcinoma, though of course it is the histopathology that is going to ultimately determine the nature of the lesion. And this is something which I think we already discussed. AJCC classification for OSSN cannot be used for surgically excised lesions treated with topical therapy or mucoepidermoid carcinoma. Yeah, so I think this is what we've been trying to say since the start of the webinar that it's for lesions that are treated with topical therapy where you don't have a biopsy and therefore histopathology is when there's no rationale of using AJCC classification, and 61% the people have responded. So with this, we move to the next talk. Dr. Rama, can you please take over? Dr. Rama?
Can you hear me now, Geeta?
Yeah, we can hear
you. Good evening, everybody, and welcome to this webinar. So we have 2 survey questions before the next topic on histopathology. The first one is, if the excised tissue submitted for histopathology, the answer was 100%. The other question was, do you actually check for the edge and base clearance? The response was close to 90%, which is very encouraging. Now we will go over to Dr. Kaustubh to talk on the pathologist perspective in OSSC.
Thank you, Dr. Rama. Thank you, Dr. Geeta. Okay, Dr. Geeta and Dr. Santosh have already emphasized the role of histopathology in ocular surface squamous neoplasms. Okay, so is the screen visible?
Yep.
Is the screen visible?
Yes, yes, yes.
Okay, so you know, when I was a postgraduate student, I had conducted this survey in the hospital. How many times does a clinician approach the pathologist and when? So would anyone want to answer this? And this, you know, please don't get offended. This doesn't, you know, apply only to ophthalmologists. It applies to all clinicians. So the response that we got was very surprising. And the most common response was when the biopsy report is delayed, followed by when the diagnosis does not match the clinician's intuitions. Then the diagnosis was something that was unheard of. And, you know, sometimes when the report misses something that you're looking for. And, you know, very funny, but very true, when the pathologist needs to charge less for a patient who cannot afford it. You know, 2 decades later, I think the situation still applies and not much must have changed now. So when do you first approach a pathologist? I think, you know, one should approach a pathologist even before you decide to operate, because one would want to know how to send a specimen, what are the tests done, what kind of sample is needed. So let's try and answer all of these questions. Coming back to today's topic of discussion, ocular surface squamous neoplasia. Now let's look at these eyes from patients. How would you approach this diagnosis, presuming that the clinical evaluation has been done, you have done your rose Bengal staining, you have done your slit lamp examination? How would you like to go about? So there are 3 different ways one can go about. One is you can do impression cytology. Second, you can go in for a scrape cytology. And third, of course, is a biopsy. Usually we go in for an excision biopsy. Now, what is impression cytology? Impression cytology, what we do is we use a nitrocellulose paper. We cut it into small pieces. Usually the paper that is used is has a pore size of about 0.22 to 0.44 micromicrons. Now you place this paper over the lesion for about a good 2 to 3 minutes. You take it off, then you put it in the preservative. Now the preservative can either be a combination of alcohol, formaldehyde, and glacial acetic acid, or it can be just simple 90% isopropyl alcohol. Now you put this either in a Kaplan jar or you put it in a Petri dish. If the laboratory is in the same facility, you can just send it in a Petri dish. But if it is, you have to send it somewhere distant, a Kaplan jar is better. Seal it properly, send it across. Okay. Then the other thing that we can do is scrape cytology. Now, scrape cytology, what you do is you scrape the ocular surface with a glass slide, or, you know, you can scrape it with a earbud, and then you transfer the material to the slide. I don't personally, you know, vouch for this method. One, it is traumatic. Second, usually I have seen that this method gives only superficial cells. Again, the mode of transport for this is the same. You can either put it in alcohol or a mixture of preservatives and send it in a Kaplan jar. And third, of course, is the biopsy. So what do you see? Okay. Now, when you do a biopsy, like Dr. Santosh has already said, you put it in the anatomical position, make sure that you use a Wattmann's filter paper, make sure that the edges are rolled. Edges are straightened out and not rolled. It makes a job of a pathologist easier to sample the margins. Then you can also choose to send the margins separately if you don't want to send it as a part of the whole specimen. The whole thing, you put it in a polythene bag which contains 10% neutral buffered formalin, and you transport it to the lab. Once you put it in the formalin, it can stay on for days together, so you don't have to worry about it drying off or getting spoiled. Okay, now coming to ocular surface squamous neoplasia, it is basically, as you all know, a spectrum of lesions, which includes the intraepithelial lesions or the premalignant ones and the invasive ones. Now, intraepithelial ones include mild, moderate, and severe dysplasia and carcinoma in situ. The invasive ones are superficially invasive squamous cell carcinoma and the widely invasive squamous cell carcinoma. Now, let's look at this slide. You have the normal conjunctiva over here. You see the epithelium with goblet cells, and below it, underneath, is this substantia propria. Now, this was a diagrammatic representation which Dr. Geeta had initially shown. Now, if you look over here, sorry. Okay, sorry about this. Let me just get back. Okay. Okay, now if you look in the mild dysplasia, it is the lower 1/3 of the epithelium that is involved. As you go on to moderate dysplasia, it becomes the lower 2/3. Severe dysplasia will involve near full thickness of the epithelium, except for the few 3 or 4 layers at the top. When the entire thickness is involved, it becomes a carcinoma in situ. And then when the cells start dropping off into the stroma or the substantia propria, that becomes your invasive carcinoma. So let's look at the picture. Now, over here, you see the irregular cells are involving the lower 1/3 of the epithelium. So that becomes your mild dysplasia. Now, over here, it's the bottom half involved. So that becomes your moderate dysplasia. Now, let's look at this slide. On the right-hand side of the arrow, you will see that the top 1/10 or, top 10% is normal. Whereas on the left-hand side, the whole thickness is involved. So the one on your right-hand side is severe dysplasia. The one on your left-hand side is carcinoma in situ. If you look at this, the black arrows, if you can see, they show mitosis, whereas the white arrows, they show apoptosis. Now, these are all features of a neoplastic process. Now, I'll come back to why these features are important. Okay, now let's look at this. Now, here you see the whole thickness is involved, but there is a part of it which is budding into the stroma. Now, you can see the invasive process has just begun. So this we refer to as a microinvasive squamous cell carcinoma. Not that it has been incorporated in the AJCC staging, but yes, this is the initial phase. Now, let's look at this one. Now, here you see the dysplastic epithelium budding into the stroma. Again, this becomes your microinvasive squamous cell carcinoma. This is what I was referring to. There's no straight line. The dysplastic epithelium is pushing itself into the stroma. Whereas here, the whole stroma is involved. You can see islands of those dysplastic cells getting into the stroma. So that becomes your conventional or widely invasive squamous cell carcinoma. Okay, now what is important as a clinician when your pathologist makes a diagnosis, or what should the report contain? One, it should have what type of neoplasia it is, whether it is intraepithelial, if intraepithelial, what grade of dysplasia it is, if it is invasive, what type it is, whether it's microinvasive or whether it has gone deeper, then what subtype of squamous cell carcinoma it is, which I'll again come back to later. Also important is the pathological grade, whether it is well differentiated, moderately differentiated, or poorly differentiated. Then, of course, prognostically and for your management, what is important is the status of resected margins. Now, any OSSN will have, a specimen of OSSN will have two margins. One will be the conjunctival side, one will be the corneal side. Now, ideally, a report should have a comment on both these margins. Then comes the base involvement, whether the base is involved or whether it's free. And of course, lymphovascular or perineural tumor spread, because it is again prognostically important. Okay, now let's look at this tumor. Now the central elevated part over here is the nodular component of the OSSN. Now on the right, you have the conjunctival component. On the left is the corneal component. Now, if you go on to a higher magnification, you see that the tumor is getting onto the base. It's almost approaching the base. Whereas if you go in, when I went in the adjacent areas, I saw that the tumor was getting right up to the base. So that's what we call it as a base positivity. Now, a lot of times, what Dr. Santosh does is when he suspects base involvement, he usually tries and sends these scleral components separately so that I can make a comment on it. But sometimes the scleral component can be easily viewed in the slide itself because of its morphology. So again, the comment on a scleral involvement becomes very important. So that's one more thing that you need to look for in a pathology report. Now let's look at this eye. Now this was a OSSN which had gotten into the orbit. So Dr. Santosh decided to do an exentration. Now let's look at this gross specimen, which is a bisected picture. Now the white part over here that you see is the tumor getting into the orbit. Now this turned out to be a squamous cell carcinoma. I'm not going to get into the histopathologic details. Okay, let's look at this eye. Now here you see the tumor is actually going inside the eye in the region of the ciliary body. So that's intraocular extension of a squamous cell carcinoma. It's a histopathological picture from the same eye. At the bottom, you see the ciliary processes, and then you see the tumor going right through the sclera up to the ciliary body. So in a specimen of exentration, or when you do an exentration, what do you look for in the report? First, again, what you do in a histopathology or in an excision biopsy report, it needs to have the histopathological type and the grade. Second, it needs to have the location or the structures involved, whether it's just the cornea, it's the limbus, or it's the conjunctiva. Then there should be a comment on an intraocular extension. If yes, what parts or what intraocular tissues are involved, whether it's just the choroid or whether it's the retina, whether it's the vitreous, etc., etc. What more is important is involvement of the adjacent structures, because it is going to change your AJCC staging. So there should be a comment on punctum, the canalicula, plica, caruncle, lamella, then the eyelids. There should also be a comment on the orbital involvement, whether the tumor is limited to the ocular surface or it's getting into the orbital soft tissue. Now, if it is going into the orbital soft tissue, then your margins of resection become important. Exentration tissue will have two margins. One is the lid margins. Second is the resected soft tissue margins. So there should be a comment on both of these. Also important is the comment on optic nerve involvement. Though I have never seen a squamous cell carcinoma going into the optic nerve, yet it becomes important. And of course, perineural and lymphovascular tumor spread. So it should be an extensive report. Of course, in addition to this, there should be a comment on the pathological TNM staging. Okay, now when I say a histopathological subtype, what did I mean? Now, there are two important variants of a squamous cell carcinoma. One is a mucoepidermoid variant, something similar to what you get in a lacrimal gland or salivary gland, and then you have the spindle cell variant. Now, why are these important? These are important because they have a prognostic significance. Now, these two variants, they are a little more aggressive than the conventional squamous cell carcinoma. They are likely to recur more, and they are likely to spread a little faster than what a squamous cell carcinoma would do. Also, more recently, we had come across another type, which has a squamous component, which is an adenosquamous component, or an adenosquamous carcinoma, which will have an adeno component and a squamoid component. Now, how do you diagnose these tumors, or how should a pathologist go about it? For a spindle cell carcinoma, it is very easy to confuse it with a sarcoma on histopathology, especially when it is limited to the conjunctiva. You can think about rhabdomyosarcoma. If you can think about leiomyosarcoma. So simple pan-cytokeratin stain will help confirm the squamous nature of this malignancy. If you do a PAS stain, it will help confirm a mucoepidermoid carcinoma. Okay. Now, as you all know, clinically, OSSN will have a long list of differential diagnoses. But as a pathologist, what becomes more important in the list of differential diagnosis is something called pseudoepitheliomatous hyperplasia. Sometimes it can be so florid that it becomes very difficult to differentiate it from a squamous cell carcinoma. So what do you do? Other than the morphological features, what the pathologist can do is he can do a P53 or a Chi67 staining. In a pseudoepitheliomatous hyperplasia, the staining will be limited to the basal 1/3, whereas in a squamous cell carcinoma, the whole epithelium or the whole, the whole thickness of the epithelium will be stained. That's how one differentiates a PEH from a squamous cell carcinoma. Okay, so in short, okay, so what did we learn today? We learned about the different evaluation techniques in a OSSN. We got to look into impression cytology. Impression cytology is non-invasive. You can use it multiple times during your follow-ups. But one major drawback of impression cytology is that it will not help differentiate between a carcinoma in situ and a squamous cell carcinoma, because that needs to demonstrate invasion, and cytology is not architecture based. So you cannot differentiate between these two. Scrape cytology, I personally don't advocate it. Biopsy, yes, biopsy is something that we all pathologists are very comfortable with. How do you send the specimen? If it is a biopsy, you have to send it in 10% neutral buffered formalin. If it is a cytology specimen, you send it in 90 to 90% formalin. A 10 to 15 minutes of fixation is sufficient. And then we also learned what ideal report should have. Other than the histological type and subtype, it should have a comment on its margins, base, and other tissues involved. Thank you. If there are any questions, you can shoot them.
Thanks, Dr. Kaustubh, for that extensive and very beautiful overview of the histopathology of OSSN. And I think one question, Dr. Vikas, Dr. Munawar, any of you, when is it that you actually decide to do a frozen section, if at all, in the situation of treating OSSN?
Well, it is difficult to do frozen section. According to pathologists, conjunctival tumors, it's possible but difficult. So I would do frozen section in a situation where I have to resect a muscle. If there is lateral rectus involvement by contiguous extension, and if I want to know how much of muscle I need to sacrifice, then that is one situation where I would have frozen section. Or if it's a tumor where you don't know what it is, sometimes amelanotic melanoma, for example, can look like OSSN or mucoepidermoid component of mucoepidermoid variant of OSSN, where you want to have an intraoperative diagnosis. That's one situation where you might want to do a frozen section.
Or maybe if you are doing an exenteration and you want to know whether if it's an anterior exenteration you're planning for an orbital OSSN and you want to know whether you've taken out everything, so you send a piece of the orbital tissue for frozen.
Okay, thanks. I think one question to you, Dr. Kaustubh, that's there in the chat section is, what do you do when the pathologist says that there's insufficient material?
Okay. Now, what happens is when when Dr. Santosh usually, when he says, there's something and I don't find it, I take it that I have missed something. He's usually never wrong. So if my diagnosis or what I see doesn't match with what he has suspected, or if I don't see a neoplasm, what I do is I try and breadloaf the whole tissue. Extensive evaluation. And that's one thing. The second thing that then comes is I try and do immunohistochemistry. Sometimes a Chi-67 is very helpful in differentiating benign from malignant lesions. And only then I come to a conclusion that yes, there's nothing else to be done now. So that's when I would go and tell him probably, we'll have to go and re-excise.
Okay.
Does the management change in any way if we sort of see a mucoepidermoid or anything like that, or if you have excised everything, then you just follow the same guidelines? Because they are more invasive or aggressive tumors. So if you see a mucoepidermoid on histology, and does the clinician, change the way he's following up or doing any change?
Straight away, if it's mucoepidermoid, then topical therapy does not work. So if you ever were to have topical therapy for that patient for local tumor recurrence, or if you feel that topical therapy is required for adjuvant purposes for edge involvement, then it won't work. And the dose of radiation is higher for mucoepidermoid if you have to give.
Okay.
Regional lymph node extension is much higher.
Thanks. We'll now move ahead with the next talk. I think this has been answered in the talk by Dr. Kaustubh. And we go to the next talk by Dr. Rama Rajagopal on topical therapy regimes and recommendations. And before she actually starts her talk, a quick idea of what our responses were regarding the percentage of cases that we treat medically. Almost 30% responded that 25 to 50% of cases is what they treat with topical therapy. And the first choice of agent for topical therapy was interferon, followed by a close second was mitomycin, 0.04%. And how do you determine the endpoint of clinical management was continuing the topical therapy for 1 to 2 months following clinical resolution. So with this understanding, I think we'll, Dr. Rama, you can start your presentation. I think the actual discussion will start after this talk on topical therapy, because the entire focus of this webinar is on topical versus surgery and understanding the hows and whys of both.
Thanks, Geeta. So now that we know that definitive treatment for OSSN is surgical excision, what then is the role of chemotherapy? So essentially, we know that there can be microscopic disease in many instances. So the chemotherapy can take care of the treatment of the entire ocular surface. Also, sometimes in 5% of cases, you can have multifocal lesions in the same eye where a chemotherapy may help. The second important concern is when you have a large lesion, you're always concerned about stem cell deficiency. So you want to chemo reduce the tumor and then consider surgery. There may also be some elderly patients who may not opt for surgery or may not be fit for surgery. So the two important questions that crosses our mind is, can I consider topical chemotherapy in SCC or only in CIN? Or do I need a biopsy to confirm before starting treatment? Earlier on, there was a school of thought that these medications work only with dysplasia, but not anymore. They can be considered in SCC and CN, and the possible explanation and response Dr. Honavar has already enlightened us with. So you really don't need a biopsy now to confirm before starting treatment. There are a couple of reports which have said and talked about the role of impression cytology, where it's difficult to find carcinoma, but they use presence of syncytial sheets and inflammatory cells as markers. An occasional report which has looked at incisional biopsy of small piece to confirm the diagnosis. But the answer is you don't really have to do a biopsy before starting treatment, before starting chemotherapy. So next, what are the indications? Broadly, we have 3 indications. We have chemotherapy when the lesion is essentially small or primary. So when you say small, we probably mean lesions less than 4 to 6 clock hours or less than 2 quadrants. early recurrences in papillomatous oocysm cases, and very rarely in elderly patients. Chemo reduction, as I already mentioned, is for very large lesions where you're going to reduce the size of the lesion and follow it up with surgery. And chemo prevention is like what Dr. Honavar mentioned, when you have a margin involvement. So broadly, the chemotherapeutic agents are three. We all know about this. We have mitomycin, 5-FU and interferon. Basically, we have rich experience in using mitomycin and interferon. We have not yet used 5-fluorouracil. Each of them has a different mechanism of action, as we can see. I will just briefly touch upon the 5-FU medications because the others I will discuss as we go along. 5-FU, all the three medications need to be reconstituted. Mitomycin and interferon have to be definitely reconstituted. But as the case of 5-FU, you may or may not want to refrigerate. Also, what is preferred is to refrigerate the medication if possible. So there are two ways of giving it. What Dr. Karp recommends is a 1% aqueous solution 4 times a day. You give it for a week and then you don't give it for 3 weeks and then you start the next cycle. There are reports which are given 4 times a day, every day for a month and then taken a 1 month off. There are also reports of pulsed 5-FU treatment. Now, will it work in every case? A part of this was already discussed earlier on. If you have a nodular lesion like this, which is most often seen in xeroderma pigmentosa, or in some patients in elderly patients, or if you have scleral invasion, and if you have an early aggressive recurrence, you are certainly not considering the option of chemotherapy. You may want to opt for surgery. The second thing is about atypical or unusual lesions like this. So here this patient turned out to be an aggressive mucoepidermoid carcinoma, which is what Dr. Honavar just briefly mentioned just before the start of this presentation. So when you have an unusual lesion or atypical lesion, the key is to get a tissue diagnosis before thinking about chemotherapy. So how do we choose the patients? What are the factors we are going to consider? Let's look at systemic factors. The most common ones would be a patient who has HIV or xeroderma or is on immunosuppression. There is a recent school of thought which actually says that when you have HIV or you have a patient who is immunosuppressed, what is the possible role of an immunomodulating agent like interferon? Although earlier on we have used it and we have got reasonably good results. The other thing about HIV is I think you need to also be aware of what is the possible CD4 count to know how the lesion is responding to your treatment. As far as the other criteria is concerned, to take a look at the ocular surface, the tear film and the limbus status, because this is very important. If you're thinking of using mitomycin for your patient, and if you have a compromised surface, you certainly don't want to use mitomycin and you want to opt for interferon. Again, if you have a large lesion where the need is to chemo reduce as fast as is possible, mitomycin probably is a preferred option. Again, in papillomatous lesions, which have a lot of rapidly dividing cells, the response to mitomycin is much faster as compared to interferon from our experience. The next thing is about the cost and affordability. You definitely have to factor this in. Mitomycin, which is one bottle which contains 2 milligram, is usually for one cycle and it will cost you about 170 rupees, as against interferon, which will cost you for one cycle, which comes to anywhere about 7 to 10 days. If you use it 4 times a day, it will cost you about 750 rupees. Again, factor in the follow-up nature of the patient, because if a patient can come to you for follow-up and you want to put the patient on mitomycin, maybe yes, but if a patient cannot come to you for follow-up and you've already reached a stage where you've got a partial resolution, then you may want to use interferon in the patient because you're not worried so much about the toxicity in interferon as compared to mitomycin. Counseling is the key, because you have to tell the patient at any point of time you may have to swap from one medication to the other if the response is not satisfactory, and also opt for surgery if there is partial or no response at all. So how do you assess the response then? So you have to ensure compliance, do a periodic review, do clinical photograph and document sometimes with ASOCT. Like I already mentioned, morphology, factor in the size of the lesion and the choice of the agent before you decide whether a patient is responding or not responding. So the next thing is, how do we assess, or what are we assessing? When you're talking about response to treatment, basically looking at the size, you're looking at the height and the vascularization. When you're looking at the resolution, you're looking at whether it is complete or partial or there is no response, Also look at the toxicity and the possible rate of recurrence in a given app. Let's move on to each of these indications. We earlier said chemotherapy in small lesions less than 4 clock hours. What Dr. Shields recommends is a primary surgery in these eyes, but there may be patients who really don't want to opt for surgery. Like this patient wanted chemotherapy. So we started this patient. Our preferred choice is 0.04%, 1 week on, 1 week off. You reconstitute. After the first week, you use it along with the lubricant. You ask the patient to discard the medication. You have to refrigerate this medication. Sometimes you can also do 4 days on and 3 days off, or you can increase the gap between the cycles. The key here is to do punctal occlusion because there can be instances of punctal stenosis and systemic absorption. You want to minimize this, but the flip side to it is that if you do a punctal occlusion, you may possibly see more toxicity because of the local retention of the medication. So this is one of our earliest patients, was 90-year-old, has multifocal disease where we used interferon. The normal cycle is 1 million or 3 million. Studies have shown both work equally well. We use 1 million interferon international units per ml, and we use it continuously 4 times a day till the time to resolution, and thereafter, which I'll discuss later on. So this patient had a very good response to topical interferon treatment and has not had a recurrence. So what if your response is partial? So after taking care of basic factors like compliance, morphology and medication and adequate trial, you need to know what is the usual time to resolution. Again, depends on the size of the lesion and morphology of the lesion, but MMC in mitomycin you probably need to give at least 2 to 3 cycles, and 5 of you it will be about 4 cycles. When I'm saying 4 cycles, it means 1 week on, 3 weeks off, which means at least 4 months, and in interferon it may take anywhere between 3 to 4 months for resolution. So this is a patient who had a partial response. So what we did, we started with mitomycin, gave 4 cycles, subsequent to which we didn't see response. We spoke to the patient, we flipped interferon, and the patient had complete resolution, has a good follow-up with no recurrence. And again, another patient where we did 4 cycles, did not see much response. Patient did not want further medications, so we opted for surgery and patient did well. But here is a patient who did not respond. So actually this lesion, if you notice, is also a bit multifocal. So we did 2 cycles. When there was no response, we discussed surgery with the patient, we did excision, and thereafter patient has been doing well with no recurrence. Next we move on to the second category, which is immunoreduction. Basically you do this in very large lesions. When I say large lesions, we are talking about lesions which are more than 6 clock hours or more than 2 quadrants. So here you may have to give multiple cycles of the medication to bring it to a reasonable stage where you can do a resection. That is what we did in this patient. This patient had a follow-up 3 years with no recurrence. Sometimes when you have a multifocal lesion, chemoreduction is a preferred choice. So what we started, as you can see, in a multifocal lesion as a chemoreduction, ended up as a complete resolution with and ended up as a chemotherapy. So this is possible sometimes. As you go along, you see the response and decide as to whether you want to continue or not continue, at what point you want to stop and start surgery as an option. Again, another patient who had a pigmented lesion. There is always a doubt in mind in pigmented lesions, is there a role for chemotherapy? It does work, only that the pigments do not go away, but the lesion does respond in most instances. Patient had complete resolution. Next, moving on to the prophylactic treatment, where you have done a surgical excision, as Dr. Honavar mentioned. If you have a margin positivity, this was a HIV patient where we did resection. 2 margins were positive, we did further resection, but after the surface healed, we gave the patient mitomycin. Here we prefer to give 1 or 2 cycles of mitomycin, and if it is interferon, at least 1 to 2 months post-operatively. So when do you consider intraoperative mitomycin? As you can see here, this is a large lesion. We excised it, we got a reasonable clearance. We did put the patient on post-operative mitomycin, but had a recurrence after 4 months, where we went ahead with the surgery and gave intraoperative mitomycin, which is usually given in a dose of 0.02 milligram. You use it for 3 to 5 minutes. You dip a Wexel sponge into this solution and usually smear it along the edge of the conjunctiva, but be very careful to wash it nicely. There have not been any case reports of scleral melt following intraoperative mitomycin, but you have to be careful to examine the sclera preoperatively before you administer this. Again, what is the role of interferon injection? This is an elderly patient who had a large lesion. We started with topical interferon. The lesion did regress, but afterwards did not respond. So we went ahead with the excision, had recurrence, and subsequently we opted for injection interferon. This can be given in 3 million or 10 million international units. What Dr. Karp recommends is 3 million international unit weekly and followed by a week off. You may have to consider, depending on the response, 1 or 2 cycles. And Dr. Shields recommends 10 million international unit as a single shot and off for 3 weeks and repeat it again after a month if need be. One thing to remember is there is a possibility of flu-like reaction with injection interferon, so you may want to give the patient crocin along with the injection. Okay, then what are the concerns with these medications, especially with mitomycin, which is the most toxic of the lot? This is a patient who was referred to us with severe toxicity with the mitomycin, had to undergo amniotic membrane and bandage contact lens, also had punctal stenosis. So what do you do then? If you have a severe toxicity, you're going to stop it, take care of the surface toxicity first before deciding on what you're going to do next. But if you have a partial response and moderate toxicity, then you may want to stop and give a gap between the cycles. You want to minimize the patient's symptoms. So how long do you continue post-resolution? Basically for mitomycin is considered 1 to 2 cycles post-resolution. For 5FU it's probably about 2 more cycles, which means after the 4 months that we were talking about. And interferon again at least 2 to 3 cycles after your complete resolution. So of the 3 agents like we discussed, mitomycin has the most toxicity but is not very expensive, works reasonably well in most instances. 5FU, like I said, we don't have much experience, but 5FU, there are reports that says somewhere in between mitomycin and Intalfa. Intalfa is the most well tolerated, least toxic medication, but is a bit pricey. So studies have looked at mitomycin both in CA and SEC and said they work well in both. Like I said already, same is true for 5FU as well. Plenty of studies about interferon, and they have found both 1 and 3 million international units to be equally effective in terms of resolution. A few studies that have looked at the compared topical 5FU and interferon as a primary modality and said both work well. Again, interferon and surgery saying both work reasonably well. And Dr. Karp has published one on pegylated interferon, which increases the local concentration of the medication and decreases the immunogenicity, but is quite expensive. Again, topical bevacizumab and subconjunctival has been described. The conclusion in most of these articles is that the topical medications or subconjunctival can take very well care of the conjunctival lesion whereas there is vascularity, but may not be as well effective in a corneal lesion. Anecdotal reports of topical cetirizine in the treatment of squamous cell carcinoma as an adjuvant, and again vitamin A along with interferon has been tried in some cases. So to conclude, topical chemotherapy can be quite effective, but you have to select your patient carefully, select the agent carefully based on the morphology to optimize results. Remember, long-term follow-up is absolutely essential. This is a patient I treated in 2016. She was on steroids for some immunosuppressive condition, and she continued the medication. She came for follow-up. She was on mitomycin. She responded beautifully. After 2018, she did not turn up. Now again, she reported yesterday to my clinic with a fairly large area of recurrence. Thank you.
Thanks, Dr. Rama. So if we can have the panelists on the, unmute yourself, probably we can just have a quick discussion. So would it be safe to say that if you are talking about topical therapy, your first choice of agent would be interferon? And in certain instances, mitomycin C?
A very simple reason that interferon is less toxic and very friendly to the ocular surface. Mitomycin C is a very good option, but I would use mitomycin in patients who don't respond to interferon or response is not fast enough. 5FU comes somewhere in between. 5FU is not as toxic to ocular surface as mitomycin, not as obvious as interferon. It's somewhere in between. So 5FU may be a good option. It is inexpensive.
Right. So when you talk about the regime that you use for 5FU, since you have the experience with that, do you follow any particular regimen? For that matter, the regimens that have been described for either mitomycin or 5FU, is it just on the basis of trial and error by several previous experienced specialists, or does it have a rationale to it?
There is no, what do you call, comparative study. Head-to-head study is not there at all. It is individual fancy that people started off with the position that, okay, we have to have some lucent period between two cycles for the ocular surface to regenerate. Mitomycin C is quite toxic to the ocular surface that we realized very early on. So COG, that is the oncology group of Europe, they started off with four times a day, 4 days a week, 4 weeks. They would give 3 days lucent period at the end of every 4 days. So that I've been following that only because I want to collect data with that. Otherwise, there is no reason why we should not follow 1 week on, 1 week off, 2 weeks on, 2 weeks off, or 4 days, 3 days. Like absolutely whatever you follow, it seems to work. But of course, one thing is clear that you cannot use it continuously for unlimited time because it causes severe ocular surface.
Geeta, if I can ask a question, I would like to ask Dr. Kunal, what is his preferred choice for injection? Injection interferon dosage? What
Yeah.
would
I give 3 million international units every 3 weekly.
Right.
So your choice for injection interferon over topical interferon is with respect to compliance or with respect to faster resolution of the lesion?
Both. If there is a larger lesion involving the entire ocular surface, or at least 75% of the ocular surface, I start off with injection interferon and start simultaneously with topical interferon for a faster recovery. Suppose the patient has corneal, the extensive corneal epithelial involvement, again, I would start off with injection interferon along with topical interferon, both running together. Every 3 weekly, the patient would get injection interferon. In the meanwhile, the patient would get topical interferon. And if there are compliance issues at the first visit, we find that the patient has not used it for more than, say, 7 days or 8 days, then topical injection interferon becomes a choice.
Thanks, Dr. Onawar. Dr. Vikas, you have anything to add? You have to mute. Yeah, unmute yourself.
Actually, for some time, my connection had some problems, so I got disconnected. I could not understand the discussion.
So we were discussing about topical therapy. Probably I'll just come back to you on this, Dr. Vikas. Dr. Nikhil, you have experience with using 5FU. Do you want to share?
The advantage of 5FU is doesn't need refrigeration and it is much cheaper because even in Mumbai, for that matter, to get interferon sometimes is a big problem. The patient keeps searching here and there. Maybe that when you have institutions which are using, maybe there it's available, but otherwise it's sometimes difficult to get interferon and it responds quite fast. And most of the cases that I've seen, it's never been as toxic as the MMC which I've used in the past. So it's just the availability and convenience of use. And I wanted to ask Santosh also because that he must be seeing a lot of patients who are referred from out of Hyderabad. So for those, then do you, request a local ophthalmologist to prepare interferon, or what is the shelf life of the prepared interferon?
We teach them how to prepare interferon. We teach the patients and they carry injections back and then they use it. The only problem I find with topical 5FU is its effect on lacrimal puncta. Mitomycin is said to be more toxic to the ocular surface, that's fine. But it surprisingly does not have much effect on the puncta and canaliculus, whereas 5FU is notorious. Even patients with CA breast who receive systemic 5FU have punctal stenosis. 5FU used topically also causes punctal stenosis. So if you are using 5FU not for any other purpose but to keep the puncta patent, you might have to do a punctal plug.
That's interesting to know, Dr. Santosh, because we have always, thought thought of punctal stenosis to be more associated with mitomycin C rather than with 5-FU. And in fact, I think there's one publication of Dr. Karp's in which she specifically mentions about the side effect with systemic 5-FU, but not with topical 5-FU. So it's good to see that, you are saying that specifically with 5-FU also you need to probably consider doing a punctal plug.
Interferon is the only drug which does not cause punctal canalicular problems.
There's a specific question regarding the technique of giving intralesional injection of interferon, Dr. Munawar.
Yeah. It is not exactly intralesional. You cannot get into the lesion and give it. Suppose it is, it is not infiltrating the tenons and episclera. You give a subconjunctival injection, raising the lesion nicely. If it is partially infiltrating the episclera and sclera, then the entire lesion will not get lifted up. So it is a perilesional injection. Basically, it is a local injection which acts like a depot and keeps on releasing interferon in a high volume, high concentration for several hours. That is how it is used. It is not by any other means that it is effective. You cannot give within the lesion. It's impossible to give within the lesion.
One question for Santosh was that, sometimes I've had patient coming with a recurrence after 2 years or something like that, small recurrence. So should you call it a recurrence? Like in Telegium, we say, like 1 year is the time you get a recurrence. So is this recurrence or is this some new, pathology that is again coming up because maybe there are some risk factors which we haven't looked into, or is it residual tumor will come so late?
Right. In cancer management, if it's in the same area of primary tumor, then it is recurrence. If it's in a different area, then it is a new tumor.
I think those are the ways in which the endpoint of resolution with therapy is defined as either clinical resolution or tumor recurrence or tumor new appearance or complications. So these are the endpoints that you look for. And I think it's just for the benefit of everybody. When you talk about clinical resolution, you're looking at absence of rose Bengal staining. There is a normal conjunctival architecture and your tumor, including leukoplakic patch, has completely disappeared from the surface. That's when you term it as a clinical resolution.
And you can use OCT as well to look at epithelial thickness.
True.
So, Geeta, one last question about the role of interferon in a HIV positive patient.
Slight controversy recently, but I don't think, there's not enough data to comment on it. But it is useful. We have been using it. It's very effective.
Thank you.
So do you use it for immunoprevention for HIV individuals also once a day or twice a day like we do for XP?
Once a day, yes, I use it.
Once a day. So I think these were some of the questions that we got with respect to topical therapy and I believe most of these have been addressed. Even if you have the lesion below the upper lid on the upper half of the bulbar surface, I guess topical treatment should work. And the treatment of choice in pediatric cases of OSSN, I don't see why it should differ from the adult management of OSSN.
Except that you should look for syndromic associations such as Papillon-Lefevre syndrome and xeroderma pigmentosum, atopic conjunctivitis, VKC. These are some of the associations in children.
Right. So this is just a chart that we put across comparing all the three drugs with respect to the various parameters, and also to give a very brief idea of how much each one of them would actually cost. So probably this is just a quick reference table to tell you and gives you an overview of all three of them in one slide. This is the chart that we have recently started using for topical therapy at SN, where we try and chart out what exactly, when you start the treatment, the date of starting, the date of termination, how many cycles, if it's MMC or 5-FU, and this kind of seems to have the whole thing again in one place. So, Shabina, can we have the next quiz question? Topical MMC does not work well for subepithelial lesions due to lack of penetration, toxicity, or antifibrotic action. believe it's lack of penetration that it's not used. I think we have the next question on 5FU predominantly acts on the following phases of phases of cell cycle. So it acts on the S phase, and probably this is the reason why it's less toxic than mitomycin, which generally tends to act on all the phases of the cell cycle. I think we'll skip the next one because we've already had that answer, and we go to the next talk by Dr. Vikas Menon on the clinical features of OSSN pigmented lesions and lymphoproliferative lesions. And these were the survey responses. The risk factors that you specifically looked for in OSSN, most of them answered that we look for all these risk factors. Do you use rose Bengal stain to demarcate the extent of OSSN? Was positive in almost 60%. Your management option for nevus in 94% was to observe. And which do you consider as an indication of malignancy in a nevus is change of size and color. So with these responses, I would now ask Dr. Vikas Menon to please give his talk on the clinical overview, which will help us decide between topical and or surgical therapy.
Thank you, Dr. Geeta, for having me as part of this very interesting session. I'm really enjoying the format that you have placed everything in. The quiz and the interaction and the questions and the surveys. It's really interesting. So we've seen some great discussions on the management and the pathology of these ocular surface tumors. So we've talked about surgeries, we've talked about topical therapy, but it is very important to first of all know how these tumors may present, because I don't think there is any other tumor of the eye which can present in as many ways, which can take as many shapes as OSSN does. So that's why probably it's called the Great Masquerade. And many a times, even more experienced people are confused depending on what the patient presents with. So I'm just going to show you some examples that I've seen in my practice and I've seen in my experience. So as Kaustubh has already shown pathology beautifully, I don't need to go into any detail, just that I would like to reiterate here that ocular surface tumors can arise from any of these layers, epithelial layer or from the stromal layer. And sometimes the conjunctiva is secondarily involved, not primarily, but secondarily from any orbital pathology, as typically happens with the patients with lymphoproliferative conditions. Now, more common conditions that we see are epithelial tumors of the surface, which can be divided into melanocytic and non-melanocytic types. The non-melanocytic epithelial tumors, again, by far are more common in our situation. And if you look at it, there is a whole list of benign conditions that it can present. And there are the malignant or pre-malignant conditions, CIN and squamous cell carcinoma, which fall in the malignant category. So I'll just touch upon some very, very common benign conditions, not going into all of them, just that you see this thing, a papilliform lesion on the conjunctiva. Sometimes a child presents with this with a lot of hemorrhage and parents are worried, the referring physician is worried as to what is this. So in children, if you see a picture like this is actually nothing to worry. It's just a presentation of squamous papilloma, which can appear like a frond of vessels arising from the center of a soft tissue growth from the conjunctival surface on the bulbar surface typically. It's very red in color, looks scary, but it's a benign thing. And it can also present in elderly, the papilloma, and sometimes it's associated with HPV infection and sun exposure. And in elderly, if you see, it's less pink and the treatment here is removal, or nowadays topical interferon are also being given, but they can be recurrent problems to deal with, sometimes become more chronic situations. Even after you excise or cryo or do whatever, still they keep coming back. So oral cimetidine is now being studied as a possible agent which can help in these recurrent lesions. Conjunctival epithelial cysts form as a result of invagination of epithelium. Sometimes they can grow really big, and and the referring physician sometimes refer as they may think it's some tumor growing in, but you see that there's a translucent fluid inside. Sometimes there can be floating debris of epithelial cells inside, but this is again a benign condition which is fairly commonly seen in the OPDs. Moving on to the more common thing that we've been discussing, the malignancy, the most common malignancy which we've been discussing all along, the ocular surface squamous neoplasia. And Kaustubh has already described that it's a combination of dysplasia, carcinoma in situ, or squamous cell carcinoma. Now, OSSN presents in a wide variety of ways. There can be a presentation in the form of a gelatinous mass, as some of the respondents in the survey had pointed out that the most common presentation is gelatinous mass. Now, here you see a patient presenting with a limbal gelatinous lesion with a few feeder vessels coming from the top and from the side. So this is one of the presentations which, if seen at the limbus, is one must not mistake it, but sometimes, yes, people do think that it's some sort of an allergic reaction at the limbus, some form of limbal VKC or something like that. But there are other features also. You look at these feeder vessels here, and we'll talk about these other factors in a little more detail. The next common variant that possibly that we see is the papilliform variant. In papilliform variant, it's actually it's a mass which has a lot of intrinsic vasculature. There are fronds of vessels arising from a central core, tiny vessels arising from that, and so this tends to grow over the limbus, over the bulbar surface, and also over the cornea to a variable extent. So this is the papilliform variant of OSSN that we very often see. Diagnosis is relatively easy to make in these situations compared to the gelatinous ones, as the findings are a little more gross, and one is able to pick up these findings at an early stage. But still, we do get cases like these where even if a patient has a small problem, he ignores it and does not seek treatment at an adequate time, and you see this thing grows and grows and sometimes can encroach onto the cornea significantly. That's the point where the patient may have some problem with vision also. Otherwise, if it remains away from the center of the cornea, vision is generally not affected. You can see here a large mass, a papilliform mass with a lot of intrinsic vessels growing here, and so this is one characteristic which one must not ignore. Also, another factor that needs to be considered in the diagnosis of OSSN are feeder vessels. Now, these feeder vessels are more prominent, thick feeder vessels, and usually not very thin marginal vessels like these, but you can make out the difference. They are tortuous, they are dilated, and they are coming from the periphery and going straight into the lesion. Also, this lesion has intrinsic vasculature. So when we are trying to diagnose a case in the OPD, because things are so clear and in front of us, what we should try to do is try to factor in as many points as we can in favor of the diagnosis. And most of the times, the diagnosis is made clinically only. Biopsy is rarely required. So one thing we saw was intrinsic vasculature. The other thing we are seeing here, and the other thing we saw was papilliform presentation, and the third thing is feeder vessels. If you have prominent feeder vessels going into a mass on the limbus, it is highly suggestive of a OSSN. And then we combine all these things here. So this patient had a papilliform lesion with a lot of intrinsic vasculature and very prominent large feeder vessels coming from the periphery supplying the tumor. The next most important factor which helps us to differentiate OSSN from many of its mimics is keratin. Now, if you see keratin, exuberant keratinization on the surface, it's happening because of the mitotic activity that's taking place in these epithelial cells, and there's a high turnover of these cells, and as a result, a lot of keratin is being produced, which is getting deposited on the surface. So in a situation like this, where you have three of these factors, you have a lesion where you see intrinsic vasculature, you have feeder vessels, and you have keratin, your diagnosis is almost certain. Sometimes you may have a small nodule. It's a small nodule kind of a lesion, but look at the surface, it has keratin deposition, and there are some feeder vessels which are coming from the periphery. So all these signs are helpful in the OPD to diagnose a case of OSSN from some other benign looking mimics. Another patient who had exuberant keratinization on the surface, again with some feeder vessels which are visible and dilated prominent. These are feeder vessels and some intrinsic vasculature which you can see through even through the surface keratinization. Again, a lot of keratin producing tumor here. You can see how keratin is produced here, and that kind of reflects onto how prolific this tumor is or how aggressive this tumor is. Sometimes OSSN in our country can appear pigmented, and that sometimes can be confused as melanoma or sometimes even as a nevus in clinical situations. So what one needs to look at are other features: the presence of feeder vessels, the presence of intrinsic vessels, and presence of keratin, as you see here. So if you have all these signs, you know that what you are dealing with is not just a nevus, because yes, nevi, as pointed out in the survey, many people prefer to observe them for growth. And if you see a pigmented OSSN, which is kind of diagnosed as a nevus, so it can go undetected and untreated for a long, long time. But you must always keep an eye open and have this thought in your mind that if there is keratin deposition over there, then it could be an OSSN. So better to excise that kind of lesion. Purely corneal OSSNs are rare. Usually there is some sort of limbal involvement in most of the cases, but they are known to occur. So what you see here is an epithelial growth. Usually it does not cross the basement membrane, and so it's kind of a CIN which grows onto the surface of the cornea as a flat epithelial lesion with some fimbriated edges which keep on progressing. Topical therapy works very well in these cases, and this is the patient after just 2 cycles of mitomycin C. The other variant which causes confusion and sometimes a diagnostic dilemma is the diffuse variant. So if it's a localized papilliform type of lesion, the diagnosis is still easy to make. But when it's a lesion like this, which is flat, spreading over the surface of the eye, but in an elderly patient, most of the times this thing can be ignored and the patient can go on getting treated like a chronic conjunctivitis or something like that. You see here, there's a thin layer of gelatinous mass over the epibulbar surface. There are these tiny vessels, the rose Bengal staining happening. We'll talk about it shortly. And if you evert the eyelid, you can see that the tumor has even grown onto the palpebral conjunctiva as well. So these are the cases which can be tricky to deal with. And if you don't see the posterior most edge of the tumor that you are examining, I would suggest that it's imperative to evert the eyelid and exactly examine whether this tumor could be actually involving the palpebral conjunctiva as well and be more diffuse than you anticipated it to be. The treatment options have been discussed for this kind of lesion. I'll not go into the treatment part. Now, rose Bengal staining is a very useful adjunct. It's a cheap test. It's a very sensitive kind of test, but I would not say it's specific to OSSN. Basically, the rose Bengal stain tends to stain any denatured cells on the epithelium. So if you have a patient who has a normal tear film, who has a normal Schirmer's test, and you have this rose Bengal staining area there, and if you also have a clinical mass, then you can actually, it helps you to delineate the exact extent of the cells which may be affected, because all these dysplastic epithelial cells, all these abnormal cells, if they are not so gross as to be visible through the naked eye at the time of examination, you can still pick up some of them, and that can help you in planning your surgical resection margins. Dr. Santosh showed a beautiful diagram that he taught all of us when we were his fellows, and we still carry that practice, that when we see a patient, we stain and we try to mark out the exact margins, and then that diagram helps us in the operating room when we are trying to resect the whole of the tumor. So it's a very useful test, I would say, clinically in the OPDs. I tried to look for some evidence as to what is the percentage or what's the specificity of this thing for OSSN. So it's not exactly specific, but yes, it's quite sensitive. And there have been some reports which have been coming in literature where people have used it in oral mucosal cancers, oral mucosal squamous cell carcinomas, and there they've found that the correlation between the amount of tissue staining with rose Bengal stain is very significant when they excise that particular area and subjected it to histopathology. So that correlation is significant indeed. The other things that are helping us nowadays in our diagnosis and our management is anterior segment OCT and investigations like UBM. I am again not going into detail because these are going to be dealt with separately, but sometimes you see when you have a patient who's been operated somewhere else, you see a dip kind or a scar formation there. As part of your evaluation, it becomes imperative for you to know in your pre-surgical planning as to how deep this lesion is going. So that's where the role of ASOCT comes in. You see this patient who's had a prior surgery, there is some sort of indentation and the tumor is here and it's going inside into it, penetrating in the scleral layers also at certain places. Another patient who has a history of excision of OSSN earlier, but now presents with a hypopion, a kind of a situation where the anterior chamber is full of cells. If you look on the high magnification, it's like, whitish cells which are filling the anterior chamber. So because there was a scar of surgery, previous surgery, even if you don't know the prior history, so you have a scar of prior surgery here and you look at this hypopion kind of thing. If you look at it carefully, it was whitish cells, not typically like you see in hypopion, and a UBM reveals a thickened ciliary body. So it makes your diagnosis easier, and you know that possibly you could be dealing with a malignancy which has gone inside the eye, and it's an invasive kind of an OSSN, what Kostap talked about, maybe a mucoepidermoid or something like that. I was already stressed upon the point that it's imperative to evert the eyelids for a proper full assessment of your cases. Sometimes the OSSN may just be on the palpebral conjunctiva in a patient who's just coming with chronic discharge and chronic irritation, and there may not be any other limbal component. So it's always good to follow the basics and do a complete proper examination, and sometimes you can get situations like this. Already this point has been stressed upon by previous speakers on numerous situations. So, but I would just like to reiterate that one has to be very cautious, keep a very close eye on patients who are suffering from any of these conditions like xeroderma pigmentosa, patients who are immunocompromised, or patients with Papillon-Lefèvre syndrome, because these patients tend to have a lot of recurrences. You see this young man who's already lost one eye. Was an intraocular invasion. The eye is incised. The other eye also is having a tumor on the surface. It's a bilateral condition, really bad for the patient. So one must be very careful in dealing with these patients. So to summarize everything that we've seen so far, the signs which we should not miss and we should try to collate in our head when we are seeing a particular patient are intrinsic vessels, presence of feeder vessels, presence of surface keratin, and the staining helps you in delineating the extent of the tumor. Moving on to the next variety, that's the melanocytic conjunctival tumors. They are probably the next most common epithelial tumors after the amelanotic ones. And these are the common types that we see: conjunctival nevi, racial melanosis, or nowadays called as complexion-associated melanosis, primary acquired melanosis, and melanoma. There are pigmented cells near the basement membrane of the epithelium. These are the ones which proliferate and give rise to various melanocytic tumors. So this is the most common type. Obviously, everybody knows what it is. It's a nevus. And how can we be so sure about that it's a nevus? By looking at these tiny microcysts. So if we are able to pick up these microcysts in a pigmented lesion in a patient, you can be quite certain that what you're dealing with is this is a conjunctival nevus. These carry very low risk of malignant transformation. Yeah, at times you may see these tiny feeder vessels, but they are not really engorged feeder vessels as you saw previously in OSSN cases or in any malignancy. So they can occur, but it does not mean that it's a malignancy. Now, the typical locations are interpalpebral fissure near the limbus. It can occur on the semilunar fold, the plica, and it can even occur on the caruncle or sometimes even near the puncta. Now, at times, parents rush in with their child and say that, oh, this black spot is increasing, doctor, what to do? Please take it out. And you just need to reassure them that it's fairly common in children who are passing through puberty to experience a growth of these lesions. Sometimes pregnant women also get an increase in the size of nevi, which is fairly normal. And in case you excise the lesions, then and you send to the pathologist, the pathologist returns these samples, and the report says inflamed nevi. So inflammation can be seen within the substance of the nevi, and which gives rise to some sort of vascularization within the substance of nevi. Malignant transformation is very rare, but when should you grow more suspicious as to your nevus is turning malignant? What are the signs which tell you that? So you should be more suspicious if a patient presents with a nevus which has an onset in adulthood. Now we know that nevi are kind of congenital cell rests which are lying there, and they tend to grow slowly. But if a patient presents, it has just come up, be more suspicious. If there is history of recent growth in an adult of a nevus, or if there is color change to more dark appearance, then you should suspect a conversion into a melanoma. If any of the typical locations are not involved, but maybe it's in the fornices or maybe on the palpebral conjunctiva, so be more suspicious. It could be a malignant transformation. If there are prominent feeder vessels, obviously, and if there is a recurrence after excision, these are some of the signs which should kind of, make you more alert to the possibility of a malignant transformation there. The treatment, as was rightly pointed out in the survey by majority of the respondents, observation remains the mainstay of the treatment, photographic comparison, and excision with cryo. Most of the times we are doing it when patients are very much cosmetically bothered by the appearance of the nevus as a black spot on the surface of their eye. Cosmetically, they want it corrected. But if you are going to excise it, I would suggest you excise it completely and also cryo the edges so that any microscopic residue are eliminated. These are the associations: Carney complex and dysplastic nevus syndrome. Patients with dysplastic nevus syndrome have more chances of developing melanoma. Now, the next kind of common variety of conjunctival pigmentation is complexion-related melanosis. This is typically seen in the interpalpebral fissure. It can be bilateral, but it can be asymmetric. Sometimes even fornices are involved. This is very common in our country because we have dark skin and there is a lot of pigmentation otherwise also, which can be seen in the conjunctiva as well. The next variety of pigmentation that we see on the episcleral surface or the epibulbar surface is melanocytosis. Now, melanocytosis is important. Why? Because number one, it's not a conjunctival pigmentation. It mimics a conjunctival pigmentation. It's actually the pigmentation of the sclera or the episcleral tissues. And 1 in 400 of these cases with episcleral and oculocutaneous melanocytosis, when sometimes this pigmentation is seen with the changes in the skin as well. 1 in 400 of these cases have been reported to have a presence of uveal melanoma also. So you must examine all these patients annually, dilate their pupils and have a good look at the fundus. If they also have a hairline pigmentation, then these cases can have meningeal melanomas as well. So in appropriate situations, you need to refer them to an appropriate person as well. Sometimes this melanocytosis, as I mentioned, can be associated with pigmentation of the periocular skin, and that's when it's called oculodermal melanocytosis, and also called as nevus of Ota. So you must always ask these patients to open their mouth, look at the palate. Sometimes the soft palate has pigmentation, and in these situations, these patients may also have a more incidence of esophageal melanoma. So again, keep a careful watch. The next most important probably from the point of view of it being dangerous is primary acquired melanosis, or nowadays the better terminology is conjunctival melanocytic intraepithelial neoplasia. So this kind of pigmentation is more commonly seen in Western countries, but again, I would say it's not uncommon to see in our situation also. Seen in unilateral middle-aged people, uh, people who have more smoking and hypertension and other significant risk factors. So how it looks like, let us see that. So it's, as the name suggests, it's an acquired melanosis. So patients in their middle age come to the OPD with flattish acquired pigmentation, which is ill-defined with irregular edges on the bulbar conjunctiva, sometimes even palpebral conjunctiva, sometimes even the fornicial conjunctiva. And they might say that, this kind of increase, this is increasing and decreasing at times. So this is typically associated with waxing and waning character. Now, why this is so important, why this pigmentation is so important, is because of this. The primary acquired melanosis can be of two types. One is without atypia and the other one is with atypia. So with atypia, there is almost 46% risk for development of conjunctival melanoma. And if these atypical melanocytes in the epithelium are located in some layer other than the basal layer, then it's almost 90% risk. And if the patient with atypia, the atypical melanocytes are showing epithelioid cellular features, then the risk goes up to 75%. So that's why this is very important. And how to manage these PAM lesions is a question that very often comes up. So if it's just a small lesion, less than 3 clock hours, then you can choose to just observe this lesion or completely excise the lesion, as we do for other tumors with cryotherapy. But if it's a large lesion which is covering more than 3 clock hours of the bulbar conjunctiva, then you have to do incisional map biopsy from all the 4 quadrants, even the normal looking quadrant, and you have to apply double freeze thaw cryotherapy to all the affected pigmented sites. And if there are areas of nodularity or vascularity in the lesions, then whatever areas are more suspicious, you have to do a complete excisional biopsy of those suspicious areas. Plus, you have to take map biopsies from the adjoining flat PAM areas and even the apparently normal looking areas. Topical mitomycin has a role, but not as good as it has in OSSN. Then there can be secondary acquired melanosis. So if you see a patient coming with this kind of pigmentation in the fornix, an elderly patient who's been on anti-glaucoma medication for long, so a lot of medications also cause this kind of pigmentation, and it's not necessary to subject everybody to a biopsy. This obviously is not a confusing picture at all, and this is what a PAM lesion can lead on to: conjunctival melanoma. Conjunctival melanomas arise most often from PAM lesions. As you see in these two cases, both the lesions are quite diffuse. You can see the bulbar surfaces involved, the fornicial surfaces, fornicial areas involved. There's a large mass in the upper fornix, even spilling onto the lid margin. Again, in this patient also you have so basically what this is showing is that there must have been a lesion, a PAM with atypia pre-existing, which probably went unnoticed, and you have this kind of lesion which is like PAM area, and you have the growth of a melanoma, nodular area, the dark pigmented area. So in that zone. So this is arising from PAM. So that's why PAM is so important. It should never be ignored. And so 20% of melanomas arise from nevi, 75% from PAM, and about 5% arise de novo. Now, melanoma is, as we all know, it's a very deadly disease and carries a high risk of systemic metastasis and regional lymph node metastasis. It also has systemic metastasis to lung, liver, GI tract, skin, even bones. And the management options have already been discussed. I'll just revise few: excision if it's localized plaque, or even exenteration. Sentinel node biopsy is something which has been advocated for melanoma lesions because it metastasizes to lymph nodes at a very early stage. So any tumor which is more than 2 millimeters thick, the recommendations are to do a sentinel node biopsy. Now, it's not something which we have as available everywhere. So that is a challenge. And it's a deadly tumor. Even in Western countries, the mortality rate is quite high, almost up to 38 to 40%. But in our country, probably it's even worse. Moving on to the next section, that's the lymphoproliferative tumors. Lymphoproliferative tumors can be considered to be of three main types: reactive lymphoid hyperplasia, atypical lymphoid hyperplasia, and conjunctival lymphoma. It's mainly a spectrum of lymphoid changes that we see in conjunctiva. So, like this child presented with a large mass medially, which is pinkish in color, and but it was well defined. It's not. It's looking like it's going into the fornix, but it wasn't. It was mobile, and one could feel it as a well defined lesion. So it was excised, and what it turned out to be was a benign reactive lymphoid hyperplasia. On the other hand, this patient presented with a much more diffuse pinkish kind of lesion on the superior part of the bulbar conjunctiva, with some vessels growing in, and they are not very clear, but there were intrinsic vessels also. If you see those intrinsic vessels within the lesion, small vessels, very fine vessels. So that also, with the color, typical color, you know what you're dealing with. And most of the times, if you must, in fact, I would say you must do an imaging, an MRI in these situations, and you will find out that probably it's an orbital lymphoma, which is secondarily involving the conjunctiva. Now, what is important about lymphoproliferative conditions is this: you need to know what is the progression rate to systemic lymphoma. You can treat the local lymphoma, that's not a problem. You can excise a small lesion, or if it's an orbital lymphoma, then you can subject the patient to radiation, and these lymphomas just melt. They typically are mild lymphomas, which have a good prognosis. They are B cell lymphomas, and they have a very good prognosis, and they respond beautifully to radiation. But important thing is this, is that in unilateral cases, there is almost a 17% chance of it progressing to a systemic lymphoma. In bilateral cases, it's almost 47% chance of progressing to systemic lymphoma. And if it has to happen, then you should know when it has to happen. You can't just follow up the patient for 1 or 2 years and then forget about it. Because in 15% of patients, systemic lymphoma occurs at 5 years. And in about 20% cases, it has been reported to occur after 10 years. So these patients will require a long-term follow-up, an annual follow-up. And you must also take a medical oncologist into confidence. So it's like a team effort. So you need to keep screening these patients even years after your primary treatment. So I'll just conclude here. So as we've all seen that, a good understanding, and that's why we all are here. So it's imperative, and our timely management can be really life-saving in these conditions. Thank you very much.
Thank you, Dr. Vikas, for an excellent overview. I think we will go ahead with Dr. KK's talk on a pathologist's perspective of pigmented and lymphoproliferative lesions, and then we'll take the questions after that. Dr. KK?
It was an excellent talk, Dr. Vikas, and I think there's a lot of discussion happening on the chat box about your photographs.
Are you able to see, Doctor?
Yes.
Thanks a lot, Dr. Geeta, and the organizers for giving me a chance to talk. So the talk will be in a form of a dialogue. And I also compiled the list of eminent ophthalmic pathologists, because we don't see much melanomas or pigmented lesions in the Indian population. We see more of ocular surface tumors. Whatever knowledge we have gained on melanomas is from the Western literature and reading the textbooks. The first question is, I think, has been addressed. As a private practitioner or somebody practicing in the institute, how will you send the sample to the pathology department? Yes, the sample must be sent in at 10% buffer formaldehyde, because you can ship the samples not only within the state, but also somebody is practicing in Delhi. They want to get opinion from Dr. Santosh, or they want to get opinion from some other state. They can ship the samples in formaldehyde, and it will be quite stable. There will be no putrefaction. Make sure the bottle is tightly closed. That's very important. suppose this is out of context, but I want to tell. Suppose you have an ocular cicatricial pemphigoid diagnosis, don't put on formaldehyde because you need to do immunofluorescence to establish the diagnosis. So ask for Mitchell transport medium, and in this you can transport to a lab where they do routinely immunofluorescence. Like if you are practicing in Chennai, we want immunofluorescence, we can send it to Delhi. So this Mitchell's medium can work in room temperature and it preserves the epitopes. So if you are thinking of ocular cicatricial pemphigoid, you have to put it in Mitchell's transport medium. Don't put in formaldehyde. Next, people are now trying to do mutation studies for therapy. In this context, you can do the study the BRAF mutation in formaldehyde fixed samples, or you can also do on fresh sample. But some of the commercial labs have a policy. They will do BRAF mutation only when they see 25% of the tumor. So you have to be very, very careful. And there are limitations when you do on paraffin sections and on fresh tumor sample. So you must send to the place where they routinely do the BRAF mutations. Then what clinical information you need as a practicing pathologist when you see pigmented lesions? Duration of the lesion, age, site, is it single or multifocal? Is it any rapid growth recently? Any family history of pigmented lesions or tumors? Any medical history, like any immunosuppression, medications previously used, any previous history of malignancies? And we always appreciate a clinical image so that we could understand the morphology. And if you are talking of a margin clearance, this will give us a view of the lesion you are talking about. So this completes to some extent. And how easy is to diagnose pigmented lesions on histopathology? See, this is something like clinical. On the first image A, you see a frank pigmented tumor. You can tell it is melanoma. On the other image, you see it is an amelanotic mass. It is anybody guess. It could be in OSSN, but using histopathology and immunohistochemistry, you used to use specific markers for melanocytes like SN-RED, SOX10, HMB45. We make a diagnosis of melanoma. I still remember the case 20 years back when I was sitting with the Professor Narsingh Rao and signing out. We had a amelanotic mass in the conjunctiva. So we thought it is lymphoma. So Professor Rao told, KK, take it to Bharat Nathwani. So Bharat Nathwani was a lymphoma expert. So we sent the sample block to Professor Bharat Nathwani. Next day, Nathwani tells, hey, this is my amelanotic melanoma, not lymphoma. So Professor Rao looked at me and laughed. So it is very difficult sometimes to differentiate an amelanotic melanoma from based on morphology. You need immunohistochemistry. Then, how many types of conjunctival pigmented lesions are there now? See, this is a very important thing. Like in 1980, when the WHO classification came, you could see it is very fairly simple. You had a nevus, and you had PAN with atypia, without atypia, and then you had the melanoma. This is 1980, but today we are in 2020. Lesions are getting added from benign melanosis to Spitz nevus to spindle nevus, epithelial melanocytoma, deep penetrating nevus with BRAF mutation, blue nevus, inflamed conjunctival nevus, compound nevus, combined nevus, PAM, subtypes, and melanoma. So the lesion is getting expanded. So the diagnosis is getting more difficult and complicated because we don't see much of these cases. I mean, we occasionally see an odd case. Definitely, the pathologist's chance of making the mistake is quite high. The next question is, are there subtypes in conjunctival melanoma? No. See, it is evolving. This area is dynamic. We have melanoma de novo. It can come from a nevus. It can come from a PAN. Then they talk of, can we look into melanomas based on the mutation status or any other driver events, so that this is based on target therapy, whether we can give therapy for this subtype or not. Then came this paper in 2020 August, where they applied a classification of conjunctival melanoma without metastasis and with metastasis using microRNA profiling. So they were surprised to see that it clustered into two groups. So I would not be surprised in the near future, as we have the class 1 and class 2 classification for uveal melanomas, and skin melanomas, the same application would also hold true for conjunctival melanomas, whether it is a class 1 conjunctival melanoma or a class 2 conjunctival melanoma. So, because one study tells the conjunctival melanomas are like skin melanomas. The recent study tells the conjunctival melanomas are more like a mucosal melanomas. But in the future, we can expect more of a molecular stratification of conjunctival melanomas. Next, can we overdiagnose a nevus as a melanoma? This is something as a pathologist, we need to answer. There are problematic areas because this conjunctiva comes in a special area. The reason because it belongs to the site called nevus of special site category. When a nevus occurs in the scalp, in the conjunctiva, in the inframammary area, in the toe, these are all special site area that they would appear histologically atypical or show dysplasia, but they may not be melanoma. So if the pathologist is not aware that these nevi, which occur in special sites like scalp, conjunctiva, breast, earlobe, infra-umbilical areas, and leg, that since they happen in this special site, they may look atypical, but they are not melanoma. If this is not clear to the pathologist, then he may tell all atypical nevi as melanoma. However, these special type of nevus occurring in the conjunctiva can complicate the life of the clinician and pathologist. Like people have reported Spitz nevus of the conjunctiva, Reed nevus, melanocytomas. I will share some of the examples to see how this is very tricky for the clinician and for the pathologist also. See this image. You see first it was not pigmented, then it became pigmented, and this is the histopathology. These are all nevus cells. I'm going to higher magnification. As a morphologic pathologist, what we see, any nevus, we look for maturation. That is, the cells in the top must be larger, cells in the bottom must become smaller. This is called as the maturation of the cells. This classically happens in nevus. That's what we tell maturation is intact. But see here, I have marked it in this yellow circle. You find the large nests of cells are there. Here there is loss of maturation. So conventionally, when pathologist sees there is loss of maturation, so he will go towards making a diagnosis of melanoma. But if he's not aware that there is an entity called as combined deep penetrating nevus, then we are in for trouble. The problem is this combined deep penetrating nevus is BRAF 5600E mutation positive. Yes, majority of the conjunctival nevus also expresses BRAF 5600E mutation positivity. So based on mutation status or morphology, we must not make a diagnosis of melanoma. So there are special immunohistochemical markers, like we can use a combination of beta-catenin, which shows the cytoplasm and nucleus in one set of cells and only membrane another set of cells. In this way, we use a combination of markers like beta-catenin, cyclin D to make a diagnosis of deep penetrating nevus. The lower image here shows the BRAF positivity in the nevus cells. In this context, we must be aware of these entities like combined deep penetrating nevus, which is BRAF mutation positive and must not be mistaken for a melanoma. So this is very important. It is a benign lesion. It must not be overdiagnosed as melanoma. Then routinely what happens if a novice or a general pathologist not exposed to ophthalmic pathology sees the conjunctival nevus, he can mistake it for a melanoma because of the presence of goblet cells. He may mistake it for a pegytoid spread. There may be not much maturation in conjunctival nevus. See this junctional nevus, which can be mistaken for a pegytoid extension by the novice. Then there is entity by Jacob Peer, where they talk this entity called as inflamed juvenile conjunctival nevus. This entity comes in children, it is rapidly growing, and so the parents are concerned whether it is a melanoma. But what Jacob Peer and Hilf Zamir, the first author, has reported is there are multiple cystic inclusions of the conjunctival epithelium inside this nevus cells, and there is mucin. So the lot of inflammatory cells and eosinophils are attracted towards it. And this must not be mistaken for a melanoma if you are aware of this entity. Then there is another entity called as combined nevus of the conjunctiva. You see, one circle shows one type of nevus cells. The other yellow circle here shows dendritic cells. This was signed out as a melanoma by a general pathologist because you see clinically there are some satellite lesions. So when you see like this, something looks like a satellite lesion, and you are not aware that there are two types of nevus happening here. One is the classical nevus, other is a blue nevus. You may mistake this for a melanoma. So this sort of nevus, combined nevus, can come in the conjunctiva and mimic melanoma. And it also shows the cystic inclusions, which Vikas Menon talked about it. So the next question is, can we do an incisional biopsy in a melanocytic lesion of the conjunctiva? This is from Dr. Shields. She tells, we avoid incisional biopsy for risk of local tumor dissemination and possible recurrence. So I will not, she does not recommend an incisional biopsy for a melanocytic lesion of the conjunctiva. Then the next question is, you do a biopsy of an excisional biopsy of a melanocytic lesion. And if it's pigmented, it is easy. But if the nevus is not pigmented, it's a challenge. The report comes as benign epithelioid melanocytoma. The question is, should I go and excise the entire lesion or reassure the patient since it is benign? This is really a tricky question. I'll see. See, what happens is benign epithelial melanocytoma, it can be very deeply invading. Here you find it is invading into the muscle fibers. There could be also a perineural invasion. So if you are not aware of this entity called as benign epithelial melanocytoma, you can mistake it for a melanoma. The other possibility is cells, when you do a bleaching. Bleaching is a procedure where we use some special chemicals to remove the melanin pigmentation, and we look into the morphology of the cells. It is so bland looking, it is so deceptive. So you may, the pathologists may think it is nothing to worry about it. But there are benign epithelioid melanocytomas has a chance of sentinel lymph node metastasis as high as 46%. So this is something very tricky. At one hand, you must not over-treat benign epithelioid melanocytoma as melanoma. On the other hand, you must make sure there is complete margin clearance as it can go to the sentinel lymph nodes. But this is the statement. Conjunctival melanoma, how bad it is? Is it like uveal melanoma? What Dr. Shields tells us, they are deadly. They are rare, but they are deadly. So conjunctival melanoma, I'm not going to go much into it. It has got poor prognosis, and people are looking into mutations and all these things. This is the histopathology of melanoma. You find the cells in the conjunctival stroma. They are very atypical. They are very angry-looking cells. So the next thing is, I must really tell, one of the greatest people whom I admire, who contributed a lot to the clinical thing in conjunctival melanomas and uveal melanomas, is Professor Jerry and Karoshitz. So as a pathologist, what should I give to the clinician? Or what does the clinician look from the pathology report of a melanoma? Look for tumor thickness. Is it more than 2 millimeters? Is there any ulceration? Is there presence of mitotic figures? Is it spindle or epithelioid cell type? Is there any lymphatic or vascular invasion? Is it microsatellitosis? So these are some of the points which the report has to capture in a melanoma report. Then how will you indicate the need for a sentinel lymph node biopsy in the conjunctival melanoma? Yes, there are some criteria that we have to follow. It is a safe procedure. That's what I understand from literature. Sentinel lymph node biopsy is a safe procedure. It should be considered in two categories. One, when the melanoma is in non-limbal location, or the conjunctival melanomas are greater than 2 millimeter thick, or the histopathology shows ulceration and presence of mitosis greater than 1. These are two situations where they advocate sentinel lymph node biopsy. The question is, do we routinely, Richard Maria's lab was to discover the BRAF mutation which led to the development of the drug. Do you routinely perform a BRAF marker, or does any other marker, does it help us in testing in conjunctival melanomas? That's a question which people ask us. Yes, there are markers at there. There are a lot of markers, 3 to 4 markers at there, BRAF, NRAS, NF1, and KIT. So it all depends because as I told you, conjunctival nevus per se, a subset of it expresses BRAF mutations. You have to be very careful. There are situations where you are not going to do BRAF mutation for a melanoma which is small or less than 2 millimeters or which is not ulcerated. Maybe you are talking in situations where it is going to be metastatic melanomas or it has gone to a new lymph node. What I understand from literature is they do a combination of markers, putting on only BRAF inhibitors that could be resistant. So they do 1 or 2 markers. They do BRAF, NRAS, or KIT so that they can use a combination of drugs. I think Dr. Santosh is a better person to talk about this because people who are practicing oncology can talk about targeted therapy, but there are a panel of markers which you can do on conjunctival melanomas which are aggressive or metastasized. Can we absolutely differentiate? That's what people want to know. As a pathologist, can you absolutely differentiate a PAM with and without ATPR? This guy is a sterling, amazing contribution to uveal melanoma on gene expression profiling, class 1 and class 2. So yes, this is PAM without ATPR. You find that there is no melanocytic proliferation. There is no ATPR in the cells. Now see the ATPR. This is PAM with ATPR. You find the cells, there is no loss, there is loss of polarity. Cells are disturbed, they are angry. This is PAM with ATPR. There is grading in that, whether it is a spindle cell type or epithelial cell type. So definitely as a pathologist, as a morphologic pathologist, people can differentiate between PAM without ATPR and PAM with ATPR. Is there any role? This is the new book of AF2 WHO classification of intraocular tumors has come. Please, all of you, if you have a chance to get it. Is there any role for frozen section in melanoma? Any red flags? I have not encountered any frozen sections in melanoma, but I don't think we need to do a frozen section in melanoma. This, as I think Dr. Santosh has earlier mentioned, if you have an amelanotic mass, you think it is OSSN, that time you do a frozen section, but usually it is not recommended for melanoma. Any red flags? Yes, you do an. I don't know much about this thing because if it's going to be a nevus in a young child, you know it is a nevus. If an elderly guy comes with a rapidly growing pigmented lesion, you are worried about melanoma. But we don't recommend frozen section for melanoma. I have not seen frozen section being done for melanoma. The next thing is we switch gears to lymphoid lesions. Yes, with some, can you differentiate between a reactive lymphoid hyperplasia and lymphoma? Yes, with light microscopy and with the support from immunohistochemistry, we can differentiate reactive lymphoid hyperplasia from lymphoma. The pathologist uses a panel of markers. They use a panel for B cell, T cell, plasma cell, and they are able to make a diagnosis of lymphoma. But there are some situations where, as the previous speaker Vikas said, atypical lymphoid hyperplasia, where immunohistochemical markers may not be helpful. That time we have to revert to molecular techniques like gene rearrangement by PCR, which can tell us whether it's going to be a borderline spectrum or it goes towards lymphoma. This is just a representative from our lab. You have a round cell tumor. Then this is how the immunomarkers will come. This is CD20, membrane positivity is a lymphoma. So immunomarkers now are routinely used in all the labs to confirm the diagnosis, especially of cancers. Then the next question is, are there any subtypes of lymphomas? Yes, there are subtypes of conjunctival lymphomas. So biopsy and immunohistochemistry is mandatory. There are the marked lymphoma or extranodal lymphomas are very common, but there are follicular lymphomas, diffuse large B cell lymphomas, mantle cell lymphomas, and T cell rich lymphomas. These are the subtypes of conjunctival lymphomas. So please, histopathology is important. Clinical information, PET scanning is important to stage the lymphomas. And so far, I have discussed only about the pathologists in abroad. In India also, there are eminent ophthalmic pathologists. There are two sets of people, hardcore pathologists, and there are clinicians who do pathology, like Professor Ratnakar, I think was the first ophthalmic pathologist in India who was mentored to Dr. Geeta Vemaganti. We have LVP, we have Somashila Murthy, who is a clinician, but trained in eye pathology under Rao. We have Kostub, We have Dr. Biswas at Shankar Netralaya, our legendary Dr. Geeta. We have Dilip Kumar, myself, Samya Jakati has joined, Dr. Dipankar Das from Shankar Dev. Kalpana Babu is in UATs, but she did 1 year fellowship at Shankar Netralaya. Dr. Shantri from Aravind, and Dr. Arpan Gandhi from Shroff is doing a wonderful job, and Dr. Seema Sen and Dr. Kashyap from AIMS. So these are some of the teams in India who are doing eye pathology and helping the oncology, our ocular oncology for diagnosis. So I really thank, most of the slides I have taken from Dermpedias, and I have acknowledged the images and everything. Thanks a lot.
Thank you, Dr. KK, for that excellent overview of pigmented and lymphoproliferative lesions. In view of shortage of time, Dr. Bhaskar, I have requested if he can do his ASOCT talk. In the next session of case presentations that we will be having. And so we now move on to Dr. Santosh Honavar's talk on the role of radiotherapy in ocular surface tumors. I would also like to mention here that the management of melanoma and lymphoid tumors will be dealt with in more detail along with the cases that will be presented in the next session. Dr. Honavar.
Thank you. I'll be talking very briefly about radiation for ocular surface tumors. Now, if you have a patient like this where there is a diffuse tumor occupying about 50 to 60% of ocular surface and has scleral and limited intraocular extension, how would you manage it? Possibly 5 years ago, 6 years ago, you would think of enucleation. And if you were to do only enucleation, there would be microscopic residual, so adjuvant radiation, or do an extended enucleation where you excise the entire area en bloc. So you might not be able to put in an implant and reconstruct for cosmetic purposes, or do an anterior orbital exenteration. Now, do we have a conservative option for this? Well, we have plaque brachytherapy as an option, especially if there is full thickness scleral invasion or limited intraocular extension. Plaque can come in handy. This is the same patient after completion of treatment, and a couple of years later, he has white avascular sclera with no loss of integrity of the eye, and cornea fairly healthy and retains good vision as well. This is one more example of a patient where there is full thickness scleral invasion, very aggressive looking tumor in a HIV positive individual, and that is again following excision with plaque brachytherapy. So in these situations, what we have been conventionally doing, again, this is one more example, is that we excise the tumor with lamellar, very superficial lamellar sclerectomy, and send it out for histopathology. Pathologist maps out the areas where there is scleral invasion, base positivity, and when we go back and do a plaque after several days, this patient again, you see that he is doing well with almost no scarring of the ocular surface. The plaque is very gentle to the surface of the eye. One more patient where a secondary plaque brachytherapy was used. After excision, wait for histopathology and then do a plaque. This is a patient with conjunctival melanoma. The nodular component is easy to excise, but what about the area where there is scleral invasion? That was treated with plaque and the patient is doing well. So what kind of dose that we use in plaque brachytherapy? In OSSN, we use, if it's a routine conventional OSSN, we use 5000 centigrade. And if it's mucoepidermoid, we go up to 6000 centigrade. And in melanoma, we use 10,000 centigrade. So the recommendation for what we call is secondary plaque is that wide excision, everything else is the same. That means that you take 4 millimeter clinically clear margins, you excise it from the horizontal aspect as usual, but then you do a very limited 10 to 20% sclerectomy. Expert opinion from an ocular pathologist. If the scleral base is negative for tumor cells, then do nothing, observe. If the scleral base is positive for tumor cells, then surface plaque application. Now, what about primary plaque brachytherapy? This is a situation where there is a limited corneal stromal melt already. So if you were to try to excise it, then it is very difficult to salvage the eye itself, because there might be a perforation which we may not be able to repair because there is a tumor and there is bound to be residual tumor. any sort of graft in this situation would be detrimental. So there we apply plaque right on top of the tumor without excising it. So that's primary brachytherapy, where we don't have to excise the tumor, but it has to be relatively flat to get accommodated in the concavity of the plaque. Otherwise, the plaque will stand off and the application of radiation would be suboptimal. One more situation where we did a primary plaque brachytherapy without surgery because this lesion is flatter. This was a recurrent lesion from elsewhere. We already knew that stroma was involved, so we could apply directly on top of the tumor. That was squamous cell carcinoma. I'll just show you a surgery. This patient, as you see here, has mucoepidermoid variant of OSS, and the tumor is so much going up to the lateral rectus, and inferiorly it is coming to about 6 o'clock position, and superiorly it's almost up to 1 o'clock position, and temporally it's gone up to lateral rectus and anterior orbit. And other eye of the patient was high myopic and amblyopic. So this is a patient where there is recurrent tumor twice excised elsewhere, and we have begun the surgery, 4 millimeter clinically clear margins, and I'm using a lot of RF here to dissect because I want to minimize bleeding. Patient is being operated under local anesthesia. That's the lateral rectus being involved. We hook the lateral rectus and we are dissecting around it to see the sclera. And finally, one more muzzle hook is passed, and 4 millimeter of the lateral rectus from the clinically involved area is passing a suture there and then excising it with a bipolar. So either you do that or take a frozen section clearance that the lateral rectus is uninvolved. Then you go on to base excision, very superficial lamellar sclerectomy, and excision of the base. We already know from UPM, etc., that sclera is involved, so we can wait for histopathology confirmation. But since it's anyway sclera is involved, this patient also had limited intraocular extension. We are going ahead with plaque brachytherapy. So that is the completion of excision of the scleral component. And the corneal epithelial component, if there is any, that has to be excised as well. And the margins are separately sent for histopathology. And then you mark the area where the first plaque has to be placed. Obviously, plaque cannot be as large as the tumor was, so we rotate the plaque. So that is the first placement of the plaque, and it takes about 24 hours of radiation in a semi-hot plaque. And we see that we haven't covered the cornea so much. All right, so then we go ahead and do the rotation and treat the superior aspect of the tumor bed. And then we do a third rotation to treat the inferior aspect of the tumor bed. So if you have a large plaque, then obviously you can treat it at one go, but such a large plaque is currently not available. It has to be customized. Then we do the excision edge cryotherapy as is conventional. Base cryotherapy for the corneal component, which the edge of the plaque has to overlap the cornea by at least 4 millimeter to treat the corneal component, which sometimes is a problem. We can't treat the lateral edge then. So we cryo the corneal component and then suture the muzzle back in a hang back position, apply glue and put in an amniotic membrane. And in such patients, symblepharon ring would be necessary, and we have covered the entire cornea with AMG so that the patient remains comfortable, and a suture tarsography as well. So that is one way of managing a primary plaque. The results are very good. In fact, we have about 90% eye salvage. 10% do fail either because of local tumor recurrence or recurrence intraocularly. This is a patient multiple times operated melanoma elsewhere and has a diffuse tumor involving the sclera and the peripheral cornea. And on imaging, these are ciliary processes, and one part of the tumor has actually gone into the ciliary body. So this was a situation where we had to either do extended enucleation or exenteration or try to salvage the eye, and the patient was very keen on eye salvage. So here again, this is surgery, 4 millimeter margins. The patient had a PAM from which the tumor had started off. So we excise the tumor first, and that superior area is of PAM. Concentrate on the tumor and excise it. Again, the muzzle is hooked and the tumor is very gently, carefully separated from the muzzle, and muzzle again has to be resected here. That is the PAM component that is being excised. And we look at the phonesis very carefully for any hidden phoneal component. Apply alcohol for the corneal epithelial component, superficial sclerectomy, suture the muzzle back. You don't have to worry about complete excision of the tumor from the sclera because we are anyway doing plaque brachytherapy. Here we could actually cover the 3 to 4 millimeter of peripheral cornea with plaque because the temporal extension was not so much. Again, rotated for the infratemporal component, excision edge cryotherapy and amniotic membrane. So it's a very fairly simple, straightforward procedure, but you have to have plaque accessible to you. Symblepharon ring invariably placed and a suture tarsorrhaphy invariably performed. And this is how the patient looks after about 6 months. You can see ocular surface nice and healthy. There is hardly any limb stem cell deficiency and patient maintains good vision because there is very little chance of radiation, retinopathy, ciliary body atrophy, etc. In melanoma, we use the same plaque, 10,000 centigrade for 6 millimeter, 8 millimeter thickness. Here we are talking about 2 millimeter thickness. So sclera doesn't get even as much dose as uveal melanoma gets. So it's a safe procedure. Corneal melt hardly ever is a problem. Cataract may be a problem if you have done a rotational plaque 3 times. Acceleration of cataract may be a problem. Next bit of radiation is about advanced OSSN. Like this patient, young patient, who had been excised a couple of times earlier elsewhere, and you see that he has symblepharon on the medial side, and he has intraocular extension, ciliary body extension, and choroidal extension as well. Young man who still has about 20/60 vision and he wants to salvage the eye. He is not keen on enucleation or exenteration. This is what his intraocular component looks like with limited retinal detachments. And so the nasal side, his temporal retina is fairly healthy, his optic nerve is healthy. So what do we do with him? Either enucleate or exenterate or do radiation. So plaque may not work here so much because we do not have space there. He had very severe symblepharon and we didn't want to meddle in that area again because now he has not much of external disease. He doesn't have any conjunctival disease, but he has mainly intraocular extension. So if we had to open up that area, that would have created problems. So we thought, and this is MRI showing nice choroidal extension and ciliary body extension. So here we resorted to what is called chemoradiation, where we give concurrent chemotherapy as a radiation sensitizer, which could be cisplatin. Any platinum-based compound is going to be a radiosensitizer. And radiation was planned very carefully by a radiation oncologist, along with systemic chemotherapy in a cyclical fashion. So several months later, the patient is doing well. His symblepharon obviously is not resolved yet. We have to take care of it, but his intraocular tumor component has completely resolved. On B scan, you can see complete resolution of the intraocular component. The ciliary body extension is gone, scleral extension is gone, and he is on MRI also. You can see that his extraocular and ciliary body extension is gone. So now plaque is expensive now, but what about the current status? Since we have Indian plaques now in 2 shapes at least, plaque has become much easily accessible and affordable. So anybody who has access to a radiation oncologist and a radiation physicist can now aspire to get a plaque if you have enough tumor volume and use it. And plaque can be customized. As I said, this is one new form of ruthenium we're trying to design, where you have plaque in the form of a symblepharon ring, and both the sides of symblepharon ring are coated with ruthenium, which means that the entire ocular surface, both the palpebral as well as the bulbar conjunctiva, can be treated at one go without having to rotate it. And this cutout is for the cornea to be safe. So this is a new design. There are other designs as well, which look like a banana or which look like in a semi-crescentric manner or a crescentric plaque, which can take care of the tumor. Now, what we are also trying to do is bring back strontium. Strontium is a beta applicator. The advantage of strontium is that it can be very rapidly applied. You don't have to leave the radiation source on the surface of the eye. So this can be applied for a few minutes. That's all it takes. It is very safe. Only side effect is cataract if you go too close to the equator of the lens. So if you are slightly away from that, then strontium is an excellent source. And we are again designing it and trying to bring it back. It is not currently available. Only one company in Russia makes it, not easily accessible. So this is being made in India now. So in conclusion, I would say that plaque brachytherapy helps provide eye and vision salvage in ocular surface tumors with corneal, stromal, scleral, and even limited intraocular invasion. Limited intraocular invasion would mean that there is 5 to 6 millimeter ciliary body or 5 to 6 millimeters choroidal invasion. If a tumor is beyond that, then plaque is possible, but the complications become higher. Role of chemoradiation is unexplored or underexplored in ocular surface tumors with intraocular extension. And I just showed you a case, just one case. We have one more with the short-term results, which seems to be a good option at this point in time. So that's
Excellent talk. I mean, we have learned so much about plaque radiotherapy, and I think it's such a significant addition to the armamentarium of tumor therapy. And initially, when you had significant scleral invasion, and we had to do a excision and then worry about the tectonic integrity of the sclera, I think here what you're suggesting is that we do something like a shave excision at the base, following which you're going to apply the plaque brachytherapy, right?
correct.
And that would be after the epithelium heals, the surface epithelializes.
Right. If you're doing a secondary plaque, then you do an AMG or whatever conjunctival reconstruction at the primary surgery, and after about 2-3 weeks you can do it. But the problem is that whatever we do, there is some amount of foreshortening of the ocular surface, so you may not be able to apply plaque sizes are limited. We can't have a large inventory of plaque. We have a plaque of say 12 millimeter, and then the next size is 18 millimeter. If the tumor falls in between that, you're bound to use a larger plaque and you may not have enough space. But if you're doing a primary plaque just after excision, then obviously you have a lot of space. Then once you remove the plaque, you put in an amniotic membrane. You don't have to go trans AMG, trans conjunctival. Here you apply directly on the sclera, which I find very beneficial. So this may be one role for frozen section margin base assessment, intraoperatively confirm it. But the problem is that they have to take multiple sections. They have to breadloaf the tumor, which will take a lot of time. So
True. So, in that same breath, when you talk about topical chemotherapy after surgery, that would also be after the surface epithelializes, because sometimes if you have an epithelial defect and you start mitomycin C postoperatively on a bare area, that can lead to further complications. So you have to wait for the surface to epithelialize before you start topical chemotherapy as an adjuvant following the surgery. I think that was a brilliant point which Dr. Vikas Menon mentioned about the need to differentiate the pagetoid spread of sebaceous gland carcinoma from OSSN. That was one of the points that you highlighted, Dr. Vikas, if you're there.
Yeah. So while I was talking about diffuse OSSN, I showed a case of diffuse OSSN, but at times, there is pagetoid extension of sebaceous gland carcinoma that can mimic diffuse OSSN. But the pointers here would be there would be eyelid changes. There would be changes on the eyelid margin. The tumor would also involve the meibomian glands. There would be destruction of meibomian gland orifices. The margin would be distorted, and some amount of eyelash loss, which are classical signs of sebaceous gland carcinoma. Or at times you may have a focal eyelid lesion as well. And sometimes you have a focal lesion and there is a pagetoid invasion concurrently. So look at the lid signs also. The point here is should not ignore the eyelid also while focusing on the conjunctiva on the slit lamp. So move back a little bit and have a better overview of the eye as a whole.
Okay. Especially the intraepithelial invasion now has been classified as pagetoid, bovenoid, and papillary in sebaceous gland carcinoma. The bovenoid has keratin, and I was surprised. I excised and it turned out to be sebaceous gland carcinoma intraepithelial keratin, but it was on the palpebral conjunctiva. I had to do a posterior lamellar excision. Papillary variant has no keratin, looks exactly like carcinoma. That is why sometimes I wonder whether we are treating all of them right by using topical therapy without biopsy. These are some scary situations because sebaceous gland carcinoma is a killer disease. OSSN is not a killer disease.
True. I think one more practical question that I would like to ask is regarding the timing of cataract surgery after you either surgically excise tumor or treat it with topical therapy. How long do you wait before you do a cataract surgery or any other intraocular procedure?
Median time to recurrence is 1 year. So I would wait for a year and ask the cataract surgeon. I don't do cataract surgery. So I would ask the cataract surgeon to go by a clear corneal approach from the opposite side, the way the tumor was.
So you would suggest that we wait for a year before we plan for cataract surgery, a year from the time of corneal, of clinical resolution.
Correct, complete resolution.
Interesting.
And one question I have is there any experience of mitomycin in PAM with atypia?
Well, mitomycin can work in PAM with atypia, but the rate of success is very low. 35 to 50% is what is reported. And it is not exactly success because if you do a biopsy again, then PAM may have turned amelanotic PAM. So one thing that mitomycin does is that it reduces the pigment component. So there is always a scare that the PAM may have just got less significant clinically because it would have turned amelanotic. So those studies which have studied mitomycin as a treatment choice for PAM with atypia haven't done a repeat biopsy. So that is the problem. It's difficult to do repeat biopsy because.
And if you have a lesion in the tarsal conjunctiva,
Which
what is the best? If you have a lesion in the undersurface of the tarsal conjunctiva, what is the best option? Injection?
which lesion? OSSN?
Yeah. Very rarely you see that.
Injection drops, but if it's involving the tarsus already, then posterior laminar excision is the best option.
Thanks.
Any other questions from anyone in the panel? Dr. Nikhil, are you there? Dr. Paras?
Can I ask a question to Dr. Santosh?
Yeah.
Dr. Santosh, recently Beta Ismaili published a paper where she tells the periocular sebaceous gland carcinomas into two types, low grade and high grade. She talks about the role of HPV and all those things. Like, what is your comment on that, Dr. Santosh?
Well, that is a preliminary work. I think we have to gather a lot of data to say that it's what it is. We cannot easily group sebaceous gland carcinoma into subtypes. It is not to my knowledge that there is a difference in behavior. They all behave the same. Only determinants are the size of the lesion and the presence of intraepithelial component. Those two determine the ultimate prognosis.
Thanks a lot.
Any information that we have on the role of HPV in OSSN?
Many studies inconclusive.
From India? Maybe from here?
There was one which probably I think Dr. Geeta did when I was doing my fellowship in LVP. So we could not find enough evidence for HPV.
And we used cervical squamous cell carcinoma as control, but still we didn't find anything.
Okay.
The same study, she used that as the control, but because I think there is a role, but we don't know what exactly is the role.
Okay. I think if there are no other questions, then we call it a day for today's session. Profuse apologies to Dr. Bhaskar for having shifted his talk from today to the next session. And we look forward to seeing you all again in the next session on the 10th of October for the case presentations, which is usually very interesting. We have a collection of very interesting cases submitted by our members that will be discussed. And I would like to thank the audience. I would like to thank everybody who took the survey before the webinar and who sent in questions to the panelists. Of course, today's meeting would not have been as interesting and interactive without all you speakers who have given such a wonderful insight into the topic. Thanks to the entire faculty, the CSI panel, the CSI office, which has put in a lot of effort to put this entire program together. And of course, I have to thank our sponsors for today's webinar, Sun Pharma. And thank you again, everybody, and see you back a couple of weeks later. Thank you so much.
Thank you.
Thanks, everyone.
Thank you.
Thank you.
Thank you.
Thank you, ma'am. There are still few attendees. Do you want to wait?
Yeah.
Yeah, sure.